Now I think it's fine. Yeah, now I think that mm, we must be audible now. Yeah, we are audible now. We are audible now. Now I think it's fine. Yeah. Welcome back, guys. Now I think that we must be audible now. Yeah, we are audible now. We are audible now. Now I think it's fine. Yeah. Welcome back. So guys, welcome back to the online latest best learning platform Unacademy, and I am Shiv Virmani, Indian medical student and author of the book Pharmac Easy. So what's up guys? I hope you all are doing well, you all are good, you all are um working for your goals, and welcome back. And today is the second sum up session of hematology, and we'll be studying hematology. So let's just get started guys. So I hope you all must have installed Unacademy learning app on your phones or your tablets, and if you haven't, then you have to just write Unacademy on App Store or Play Store, and you can install it. Install the Unacademy app for free, right? And it's a free app, you don't have to pay anything, right? And you can take part in live special classes you can take a few tests, um, right? And you can attend the special classes from the top level of educators, that are from AIMS, Safdarjung, and all the esteemed universities. Plus, if you want to buy a plus subscription, then what all are the benefits? First of all, you can enroll yourself in all the batch courses, and after enrolling, you get a structured schedule. And I think this is the best part, because you get access to so it's just like a classroom, right? And you get an access to enter that classroom, and you get a structured schedule, you get a structured course in which you will complete your topics, and you will solve your queries, and ultimately you will fight for your goal. Plus, you get access to the live classes, you get access to the plus course, and you get access to take live tests and quizzes. All the quizzes are accessible. And if you are a second or a third year medical student, then I would refer you iconic course or iconic subscription, because it is a collaboration of Unacademy and Prep Ladder. So in this iconic subscription, you get benefit from the Unacademy. These all benefits you get here in the iconic course. Plus, with all these precious benefits, you get the benefit of Prep Ladder as well. You can access to video lectures, you can attend the QBank 2.0, you can access to rapid revision course. Plus, you get the handwritten notes of the esteemed faculties of the Prep Ladder. So if you are a second or a third year medical student, then I would prefer this iconic subscription for you guys. This is the best thing you can get. Then um, this is the choices that these are the choices that you get if you want to buy what am I writing, yeah, if you want to buy a iconic course, so you get four choices. You can buy it for 12 months, 18 months, 24 months and 36 months. And if you want a 10% discount, then you can use this code Virmani, and you can buy this course. And this is a very beneficial course if you are a second or a third year medical student. Then if you want to buy a plus subscription, then you get many choices. You can buy it for 1 month, 3 month, 6 month, 12 month, 18 month, 24 month and 36 month. So if you want to just test that what all you get in a plus subscription, or is it beneficial for you or not, then you can just buy it for 1 month, and it will cost you around 4500, and that's not a big amount if you divide it from 30. So approximately, if you are um, subscribing or paying for 1 month, then how much you pay for a day? That is only 150, and we uh, we waste this 150 daily, right, on junk foods, on um, all the things you all know, right, fast food and all. So this is just a very less amount. Plus सिर्फ 150 में you cannot get a limitation, because इसके अंदर you get access to all the Unacademy lectures. You can access all full Unacademy, right, whole Unacademy. So after paying this 150 rupees per day, you can access the whole Unacademy. And yeah, अगर आपको पसंद आए, then you can upgrade it to the 3 month, 6 month, 12 month as per your need. And yeah, and the code is same, Virmani, Virmani, and you will be getting 10% off. Then welcome to the PathoNION, and first of all, thank you so much for your response on the Pharmac Easy series. That was a pharmacology series that we have started in the month of October, and we have almost completed 96% of pathology, and the remaining 4% is not important, not so much important. So we have completed pharmacology, and with your response, I am so much thankful that I'm I can't express my feeling that you all loved the way of teaching, or you understood my concepts, you liked my notes, and yeah, for that thank you so much. And thus that was the main cause we have started this PathoNION series, because pharmacology पे इतना सारा support मिला, प्यार मिला. So we thought that we should start a pathology series that is called as PathoNION. And yeah, so we have started this series, and hope you will like the session and earlier sessions also. And yeah, let's just get started. So in this we have started hematology, and till we have not completed it, because it's a very huge thing, और बीच में काफ़ी सारी चीज़ें भी हो गई. So that's why I was unable to complete this series, or complete the hematology. But from today only we will be starting from systemic pathology. So today we have scheduled a session, right, of arteries and its disorders. Then the second session is of heart. So I welcome you to these sessions as well. यू कैन कम, एंड अगर आपको अच्छा लगे तो लाइक कर देना, अगर नहीं भी लगे देन यू कैन reply in the chat. And yeah, so this is the sum up session of hematology, and let's just jump into the sum up session. So guys, till now we have completed the bone marrow and the hematopoiesis. Then we have discussed the functions of RBC, WBC and platelets. Then we have discussed the lifespan of all the three. Then hematopoietic organs, so right from the human embryo, right from the first week of gestation, how the blood cells are produced, or how hematopoiesis is done, and then how it gets transferred to the long bones and then the central skeleton. So we have already discussed these things. Then we have also talked about the hematopoietic stem cells and how it differentiate into the lymphoid and myeloid series, then erythroid series as well. Then bone marrow aspiration technique, then bone marrow examination and the aspiration and the trephine biopsy technique. Then we have talked about the two instruments, Sala bone marrow aspiration needle and Jamshidi trephine needle. Then we have talked about this difference, and this is very important difference. You all know we have already discussed then erythropoiesis, erythropoietin, and we have discussed this erythroid series and the fate of hemoglobin, then normal values of RBC count, then red cell indices MCV, MCH, MCHC, and we have discussed the anemia, classification of anemia, general features, symptom, signs, and how you will be diagnosing the anemia. So we have already discussed these things. Then we have started with the hypochromic anemias, hypochromic microcytic anemias. Hypochromic anemia is due to the mainly iron deficiency, but there are many disorders that can produce a hypochromic microcytic blood picture. So first is sideroblastic anemia, second is thalassemia, and then third is anemia of chronic disorders. So yeah, let's just jump to the sideroblastic, because we have already completed the iron deficiency anemia. So initially we have discussed the iron deficiency anemia and the iron metabolism, iron ka absorption, its transport, its excretion and its distribution, pathogenesis, how the iron deficiency anemia takes place, then etiology, the causes, and clinical features of the iron deficiency anemia, then long standing chronic iron deficiency anemia. So we have discussed about the koilonychia, atrophic glossitis, angular stomatitis, Plummer-Vinson syndrome. Then we have discussed the laboratory findings, the blood picture, bone marrow finding, biochemical finding, TIBC, serum ferritin, serum iron, then principles of the treatment, oral therapy, parenteral therapy. Then now it's the time to discuss the sideroblastic anemia. So a sideroblastic anemia comprises a group of disorders of diverse etiology in which the nucleated erythroid precursors in the bone marrow show a characteristic ringed sideroblasts. So basically there are two type of cells in which we can see the iron granules in the cell, right? So first is siderocyte and second is sideroblast. So guys, siderocyte is a RBC and sideroblast is a normoblast, that is a precursor of RBC. So as the name suggests, cyte is a newer form or the matured form, you can say, and blast is the precursors. So sideroblast is the precursor of erythrocyte and siderocyte is a erythrocyte. So these two cells, they carry the iron granules, so that's why we call them sidero. So sidero means iron, and if you can see a erythrocyte that contains iron granules, then you will be referring it as siderocyte. And if you are seeing a normoblast, a nucleated large RBC like structure containing iron granules, then you will be referring it as sideroblast. Then siderocyte, these are the red cells containing the granules of non-heme iron, and these granules stain positively with the Prussian blue reaction as well as the stain with Romanowski dyes when they are referred to as papanemer bodies. So siderocytes के अंदर iron granules are of non-heme iron, and these granules stain positively with the Prussian blue reaction as well as with the Romanowski dyes. So these are referred as papanemer bodies. And generally we see the one or two iron granules, and thus we have called them papanemer bodies, right? And the siderocytes are normally not present in the human peripheral blood. A small number of siderocytes may appear following the splenectomy. So they are only present in splenectomized patient, right? Splenectomized patient. This is because the reticulocytes on release from the marrow are finally sequestrated in the spleen and they mature in the spleen. So if spleen is not present, then the RBC will not get matured, and in the absence of spleen the final maturation step takes place in the peripheral blood, and thus we get siderocytes, right? And the papanemer bodies in the siderocyte. Now comes the sideroblast. Sideroblasts are the nucleated red cells that are precursor of the erythrocyte, of the mature erythrocyte, and that is a normoblast. So this is a normoblast that will be containing a siderotic granules or iron granules which stain positively with the Prussian blue reaction, and depending upon the number, size, distribution of the siderotic granules, sideroblasts may be normal or abnormal. And the normal sideroblasts contain a few scattered cytoplasmic granules representing iron which has not been utilized for hemoglobin synthesis, and these cells comprise 30 to 50% of the normoblast in the normal marrow but are reduced or absent in the iron deficiency. So sideroblast क्या होते हैं? Sideroblast are the normoblast that are the precursors of the erythrocyte that are containing siderotic granules or the iron granules which will be staining positive with the Prussian blue reaction, right? And depending upon the number, size and distribution of the iron granules, sideroblast may be normal or abnormal. So a normal sideroblast will be having a few number of iron granules, but जो abnormal होते हैं they are in the abnormal ones there are many iron granules, and sometimes they form a ring around the nucleus, because normoblasts are nucleated RBCs because they are precursors of the mature RBCs. So here we will be seeing a ringed appearance of the iron, right? And so basically we get two type of abnormal sideroblasts. One type is a sideroblast containing numerous or diffusely scattered core cytoplasmic granules and are seen in the conditions with the dyserythropoiesis and hemolysis. And in this type there is no defect of heme or globin synthesis, but the percentage saturation of transferrin is increased. Then the other type is ringed sideroblast, in which the heme synthesis is distributed as occurs in the sideroblastic anemias, and the ringed sideroblast contain numerous large granules, often forming a complete or a partial ring around the nucleus, and the ringed arrangement of these granules is due to the presence of iron laden mitochondria around the nucleus. So we can see the papanemer bodies in a siderocyte. So this is the erythrocyte, you can say a matured one, right? And this is oftenly seen in a splenectomized patient. And here you can see one or two iron granules, and thus we have named these bodies as papanemer bodies. And this is a siderocyte, and generally this is seen in a splenectomized patient. Then this is a normal sideroblast, that is a normoblast. Normoblast means a nucleated RBC, nucleated precursor of the erythrocyte, of the mature erythrocyte. So this is the nucleus, and you can see a few number of iron granules, right? But here, this is the abnormal one, that is a ring sideroblast. Here you have uh, we have already discussed this thing, that we will be seeing a ringed appearance. So this is the nucleus, and you can see here these iron granules have formed a ring around the nucleus. So this is the abnormal sideroblast, and now we will be seeing the etiology, that what all are the causes that can cause this thing to a normoblast, right? So types of the sideroblastic anemia. First of all is hereditary. Hereditary because of the ALA synthetase enzyme. So ALA synthetase enzyme. So this is a rare X-linked disorder, right, associated with the defective enzyme activity of amino levulinic acid ALA synthetase that is required for the heme synthesis, right? So ultimately, you all know iron is needed for hemoglobin synthesis, right? And if this hemoglobin synthesis is impaired, then what will happen? Then the iron that is present in the RBC, that will be forming a granule or many granules, because it has not been utilized to form hemoglobin, right? Hemoglobin is not synthesized, so the iron is not utilized. So if this iron is not utilized, then this iron will form granules and it will stay in a RBC. And as you know, that hemoglobin synthesis starts from the normoblast, and if this hemoglobin fails to form after this normoblastic phase, then the iron that was present for hemoglobin will be left here and it will be forming granules, and thus RBC will not have hemoglobin, right? Is it clear to you all, guys? Please give a thumbs up if everything is clear and you all are understanding the things. So a hereditary sideroblast anemia, we have discussed that aminolevulinic acid synthetase is required for the heme synthesis, and if this thing is impaired, if aminolevulinic acid synthetase is impaired or is not doing its activity, then hemoglobin synthesis will not take place. Thus the iron that is left in the RBC will be forming the granules, and the affected males have moderate to marked anemia, while the females are carrier, because this is a X-linked recessive disorder. And if a woman is having this disorder, then she might be having a genotype of both X recessive X genes, so XR and XR, right? So दोनों के दोनों रिसेसिव होंगे अगर वुमेन में woman is a affected individual, and ultimately she gets one, so she is a carrier. But a male is always a affected individual if a male is getting XR, and that is scenario here, right? And the condition manifests in the childhood and early adult life, because ultimately HB is not synthesized, and oxygen carrying capacity would be seriously less, and patient would be having symptoms. Then now acquired sideroblastic anemia. The acquired sideroblastic anemia are classified into two, primary and secondary types. First of all, primary. Primary is idiopathic or refractory acquired sideroblastic anemia, which occurs spontaneously in the middle-aged and older individuals of the both sexes. Then the disorder has its pathogenesis in disturbed growth and maturation of the erythroid precursors at the level of hematopoietic stem cells, possibly due to the reduced activity of enzyme ALA synthetase. Enzyme is same, and the anemia is of moderate to severe degree, and it appears insidiously. Then the bone marrow cells commonly show chromosomal abnormalities, neutropenia, thrombocytopenia with the associated bleeding diastasis. The spleen and the liver may be either normal or mildly enlarged, while the lymph nodes are not enlarged. Unlike other types of the sideroblastic anemia, this type is regarded as myelodysplastic disorder in the FAB, French American British classification, and thus it can be a pre-leukemic disorder, and about 10% of individuals with the refractory acquired sideroblastic anemia develop acute myelogenous leukemia, right? So if a patient is having a primary sideroblastic anemia or idiopathic anemia where you cannot able to find the cause, then he or she might end up in a leukemic disorder, because this condition is regarded as pre-leukemic disorder and often myelodysplastic disorders, right? And secondary acquired sideroblastic anemia is due to the drug, chemical and toxic substances. So or toxic drugs, or the you can say a harmful drug is isoniazid, that is an anti-tuberculous drug and a pyridoxine antagonist, and it is mostly associated with the development of the sideroblastic anemia by producing abnormalities in the pyridoxine metabolism. And other drugs occasionally causing acquired sideroblastic anemia are cycloserine, chloramphenicol, alkylating agents, cyclophosphamide, alcohol, and lead also cause the sideroblastic anemia. All these agents cause reversible sideroblastic anemia, which usually resolves following removal of the offending agents. And hematological disorders like myelofibrosis, polycythemia vera, acute leukemia, myeloma, lymphoma, hemolytic anemias. Then miscellaneous, occasionally secondary sideroblastic anemia may occur in association with a variety of the inflammatory disorders or autoimmune disorders or neoplastic disorders such as carcinoma, mixed edema, rheumatoid arthritis and systemic lupus erythematosus. Then laboratory finding of a sideroblastic anemia. First of all, there is generally moderate to severe degree of anemia. The blood picture shows hypochromic anemia, which may be microcytic, or there may be some normocytic red cells as well. Absolute values are MCV, MCH, MCHC, and they are reduced in the hereditary type, but MCV is often raised in the acquired type. Then bone marrow examination shows erythroid hyperplasia with usually macronormoblastic erythropoiesis, and marrow iron stores are raised and pathognomic ring sideroblasts are present. Serum ferritin levels are raised. Serum iron is usually raised with almost complete saturation of TIBC, because in this iron is not involved. We are patient is not having iron deficiency, or patient is not having iron excess. Ultimately the utilization of the iron is not taking place, right? Error is in utilization, because iron is utilized in formation of hemoglobin, and this hemoglobin formation is hampered. So iron ultimately will be increased, or iron will be staying in the body because it is not being utilized. Then there is increased iron deposition in the tissues as well. So principle of the treatment. The treatment of the secondary sideroblastic anemia is primarily focused on the removal of the offending agent, and no definitive treatment is available for the hereditary and idiopathic types of sideroblastic anemias. However, pyridoxine is administered routinely to all the cases of sideroblastic anemia, 200 mg per day for 2 to 3 months, and blood transfusion and other supportive therapy are indicated in all the patients. Then anemia of chronic disorders. Pathogenesis. So a number of factors may contribute to the development of the anemia in the chronic systemic disorders, and in many conditions the anemia is complicated by other causes such as iron, vitamin B12, folate deficiency, hypersplenism, renal failure, with consequent reduced erythropoietic activity, endocrine abnormalities. However, in general, two factors appear to play significant role in the pathogenesis of the anemia in the chronic disorders, and these are defective cell production and reduced red cell lifespan. So defective red cell production or reduced red cell lifespan. So first of all, defective red cell production. Though there is abundance of storage iron in these conditions, but the amount of iron available to the developing erythroid cell in the marrow is subnormal. So that's why the mononuclear phagocyte system is hyperplastic, which traps all the available iron, all the available free iron, due to the activity of the iron binding protein lactoferrin, and a defect in the transfer of iron from the macrophages to the developing erythroid cells in the marrow leads to the reduced availability of the iron for the heme synthesis, right? And despite of adequate iron stores, bodies containing normal amounts of iron, and sometimes it might excess also, but all the iron is being captured by the macrophages, and these macrophages will not let this iron to go to the bone marrow and help for the hemoglobin synthesis. So this iron will be staying in the macrophages, right? And body's bone marrow will be having subnormal amount of iron, and thus hemoglobin will be hampered, hemoglobin production will be hampered, right? So ultimately it will be causing anemias. Then the defect lies in the suppression of the erythropoietin by the inflammatory cytokines at some stage in the erythropoiesis and hepcidin, which is the key iron regulatory hormone. And these inflammatory cytokines include TNF and interferon beta, released in the bacterial infections and tumors, and interleukin 1 and interferon gamma, released in the patients of rheumatoid arthritis and autoimmune vasculitis, right? So these are a few etiologies as well here. Then reduce red cell lifespan. Decreased survival of the circulating red cells in the chronic renal disease is attributed to the hyperplastic mononuclear phagocyte system. So a reduced red cell lifespan, decreased survival of the circulating red cells in the chronic renal disease is attributed to the hyperplastic mononuclear phagocyte system. So now the laboratory findings. Hemoglobin, here anemia is generally mild to moderate, and hemoglobin would be of less than 8 gram per deciliter, right? Then blood picture would be normal, because it is not having any such scenario where either there can be increase in the cell size or decrease in the cell size, but as there can be iron deficiency, and due to iron deficiency HB is low, and we all have studied that iron deficiency anemia के अंदर MCV, MCH and MCHC is decreased. So ultimately here also they are decreased, right? And picture can be normocytic, normochromic, but in the chronic cases it can be microcytic, hypochromic, right? And the absolute values, red cell indices, indicate that in spite of the normocytic, normochromic, MCHC is slightly low, and reticulocyte, the reticulocyte count is generally low, and red cell survival. So Measurement of the erythrocyte survival generally reveals mild to moderate shortening of their lifespan. Bone marrow examination of the marrow generally um, reveals normal erythroid maturation. However, the red cell precursors have reduced sustainable iron than normal, while macrophages in the marrow usually contain increased amount of the iron, and cases of the chronic infection often have myeloid hyperplasia, increase in the plasma cells, serum iron and TIBC. So serum iron is characteristically reduced in this group of anemias, while TIBC is low to normal, because iron is normal in the body. So why TIBC will increase, right? But in serum iron is low because all the free iron is captured by macrophages. Then serum ferritin. Serum ferritin levels are increased in these patients because all the free iron is stored and in the form of ferritin, right? And this ferritin is not available to the bone marrow, and thus bone marrow is producing iron deficiency anemia, but ultimately iron is there. Then other plasma proteins. In addition, certain other plasma proteins called as phase reactants are raised in the patient with chronic inflammation, probably under the stimulus of interleukin 1 released by activated macrophages, and these proteins include gamma globulin, C3, haptoglobulin, alpha 1 antitrypsin, and fibrinogen. And elevation of these proteins is responsible for the raised ESR commonly present in these patients. Then megaloblastic anemia, vitamin B12 and folic acid deficiency. So guys, now we will be doing megaloblastic anemia. So megaloblastic anemias are associated with the macrocytic blood picture and megaloblastic marrow erythropoiesis. So what is what is this? So megaloblastic anemia will be producing a large RBC with a normochromic hemoglobin or normal hemoglobin, but cell size would be large, and it is a defect of it is a defect in which there will be combined deficiency of both vitamin B12 and folate, and thus the cells would be large, and ultimately producing anemias. Then the second etiology is pernicious anemia. Pernicious anemia is same as megaloblastic anemia, but this is autoimmune. This is autoimmune, right? Then megaloblastic anemias are disorders caused by impaired DNA synthesis and are characterized by distinctive abnormality in the hematopoietic precursors in the bone marrow, in which the maturation of the nucleus is delayed related to that of the cytoplasm. Then megaloblasts are both morphologically and functionally abnormal, with the result that the matured red cells formed from them and released into the peripheral blood are also abnormal in shape, size, and the most prominent abnormality is macrocytosis. Then the underlying defect for the asynchronous maturation of the nucleus is defective DNA synthesis due to the deficiency of vitamin B12, that is cobalamin, or the folic acid. The less common are the interference with the DNA synthesis by congenital and acquired abnormalities of the vitamin B12 and folic acid metabolism. And before considering the megaloblastic anemia, an outline of the vitamin B12 and folic acid should be having a better understanding. So let's just discuss that. So vitamin B12 and cobalamin is a complex organometallic compound. So it is same as हीम. हीम के अंदर आयरन होता है iron is the chelating agent, you can say here here cobalt is there, so that's why इसका नाम क्या पड़ा, cobalamin. So cobalt is the center, and it cobalt is the center of the ring, and right, so it is situated within a Corine ring similar to the structure of porphyrin that forms heme. And in human, there is two metabolically active forms of the cobalamin. First is methyl cobalamin, second is adenosyl cobalamin, which acts as coenzymes. And the therapeutic vitamin B12 preparation is called as cyanocobalamin. And what are the sources of this cobalamin? So there are only dietary sources like milk, cheese, eggs. So vegetarian के लिए तो milk and cheese and all the milk, dairy products basically. Then kidney, liver, heart, muscle, meat, fish and eggs, they are the best sources for vitamin B12. So generally vegetarians, they acquire this vitamin B12 deficiency because they kind of take less amount of dietary amounts, and generally we get adulterated dietary sources or food items, so that's why we don't get the particular amount of vitamin B12. So generally vegetarians, they develop a vitamin B12 deficiency. And in contrast to folate, fruits and vegetables contain practically no vitamin B12 unless contaminated with the bacteria. Then cooking has little effect on the activity. Vitamin B12 is synthesized in the human large bowel by microorganisms, but it is lost in the feces. It is not absorbed, and right, so human can synthesize vitamin B12, but they cannot utilize it, and thus humans are entirely dependent upon the dietary sources. And the average daily requirement of the vitamin B12 is 2 to 4 mu g daily, right? So 2 to 4 mu g amount of vitamin B12 is necessary daily. So now absorption. So this is very crucial part, and this will be very necessarily utilized in the Skilling's test or Schilling's test. So this is a very important test that you will be asked in your vivas, in your MCQs and your clinics, because this is very crucial test, or this methods needs your understanding. You cannot cram, you have to understand the absorption, then you have to understand the pathology, the site of pathology, कि where is the error, and इस error को हम कैसे treat कर सकते हैं, right? So ultimately absorption is necessary to understand. After ingestion, vitamin B12 in food is released and forms a stable complex with the gastric R binder. So R binder is a form of glycoprotein found in the various secretions, example saliva, milk, gastric juice and bile, then phagocytes and plasma. On entering the duodenum, the vitamin B12 R binder complex is digested, releasing vitamin B12, which then binds to an intrinsic factor, and the intrinsic factor is a glycoprotein of molecular weight 50,000 produced by parietal cells of the stomach, and its secretion roughly parallels that of the hydrochloric acid. So ultimately, first of all, vitamin B12 gets attached to the R binder. Then with this R binder, it gets to the intrinsic factor. So this R binder, so let's just take an example. Ki there is a female child, so, and R binder is the father. So first फीमेल चाइल्ड विल बी, फीमेल चाइल्ड की केयर कौन करेगा, उनके फादर. सो दैट इज अ आर बाइंडर. सो ये आर बाइंडर इसको आगे तक लेके जाएगा, सारी की सारी परेशानी खुद झेलेगा, और जो वाइटामिन B12 है उसको कोई भी दिक्कत नहीं आएगी. देन when this vitamin B12 comes in contact with the parietal cell, then ये जो कॉम्बिनेशन था आर बाइंडर के साथ वो ब्रेक हो जाता है एंड वाइटामिन B12 गोज टू द पेराइटल सेल. राइट, आर बाइंडर का काम वहीं पर ख़त्म हो जाता है. अब वाइटामिन B12 और पेराइटल सेल से जो IF निकला, इंट्रिंसिक फैक्टर, उसका कॉम्बिनेशन बन जाता है, और ये जो है वाइटामिन B12 और इंट्रिंसिक फैक्टर का कॉम्बिनेशन फर्दर आगे जाता है. right, and the vitamin B12 intrinsic factor complex on reaching the distal ileum binds to the specific receptors on the mucosal brush border, thereby enabling the vitamin to be absorbed. Then क्या होता है, ये vitamin B12 और intrinsic factor they goes to a mucosal barrier or brush border where ये vitamin B12 it enters inside and intrinsic factor ये बाहर ही रह जाता है. Vitamin B12 only and only goes inside, right, thereby enabling the vitamin to be absorbed. Then the intrinsic factor therefore acts as a cell directed carrier protein similar to transferrin as in iron. So the receptor bound vitamin B12 intrinsic factor is taken into the ileal mucosal cells, while after several hours intrinsic factor is destroyed, vitamin B12 is released and is transferred to the another transport protein, transcobalamin 2. And the vitamin B12 transcobalamin 2 complex is finally secreted into the portal circulation, from where it is taken by the liver, bone marrow and other cells. So अब ये जो vitamin B12 और intrinsic factor का कॉम्बो बना था, अब क्या होगा, इंट्रिंसिक फैक्टर तो हो जाएगा डिस्ट्रॉय और सिर्फ वाइटामिन B12 जाएगा अंदर. वाइटामिन B12 अगेन बाइंड्स टू अ ट्रांसकोबालामीन एंड ट्रांसकोबालामीन इज द सन ऑफ वाइटामिन B12. तो ये वाइटामिन B12 विल रिसाइड विद द ट्रांसकोबालामीन एंड फिर वाइटामिन B12 अपना काम करेगा, जो कि बोन मैरो में जाके और लीवर में जाके स्टोर भी हो सकता है, very less amount, and other cells में, right. There are two major vitamin B12 binding proteins. One is transcobalamin 1 and second is transcobalamin 2, and a minor protein that is transcobalamin 3. So TC1, that is transcobalamin 1, is not essential for the binding of for the vitamin B12 transport, but it functions primarily as a storage protein, right. So it is a storage protein. TC1 is a storage protein. And TC3 is similar to the TC2 and binds a small amount of vitamin B12. So major transporter is TC2. So ये करेगा ट्रांसपोर्ट, TC1 जो है वो करेगा स्टोर, और TC3 सेम एज TC2 बट इट इज अ माइनर प्रोटीन और माइनर transporter, you can say. Then tissue stores. Normally liver is the principal storage site of vitamin B12 and stores about 2 mg of the vitamin, while other tissues like the kidney, heart, brain together store about 2 mg, right. So a huge amount, that is 2 mg, is alone stored by liver, and the remaining 2 mg is stored by kidney, heart, brain and other cells all together. The vitamins, the body stores of the vitamin B12 are adequate for 2 to 4 years, right. So it's difficult, or it's very rare condition to develop a vitamin B12 deficiency, right. And this might be due to the problem in the intrinsic factors, or very poor dietary intake of vitamin B12 over years, because body stores of vitamin B12 are adequate for 2 to 4 years, right. So you will be developing the megaloblastic anemia after 2 to 4 years of constant loss of vitamin B12 or poor dietary intake or autoimmune disorder. And major cause or अगर बहुत ही ज़्यादा फास्ट प्रोग्रेसिंग मेगालोब्लास्टिक एनीमिया है पेशेंट को, then it is believed that there is the problem in intrinsic factor. Then major source of the loss via bile and shedding of the intestinal epithelial cells, and the major part of the excreted vitamin B12 is reabsorbed in the ileum by the intrinsic factor, resulting into the enterohepatic circulation. Then functions. Vitamin B12 plays an important role in general cell metabolism, particularly essential to the normal hematopoiesis and for the maintenance of the integrity of the nervous system. Then vitamin B12 acts as a coenzyme for two main biochemical reactions in the body. First is as methylcobalamin, methyl B12, and in the methylation of the homocysteine to methionine by methyl tetrahydrofolate THF, and the homocysteine methionine reaction is closely linked to the folate metabolism. So here homocysteine will be getting converted to the methyl B12, and this methylcobalamin is beneficial in the conversion of homocysteine to methionine. When this reaction is impaired, folate metabolism is deranged and results in the defective DNA synthesis that is responsible for the megaloblastic maturation. Then secondly, as adenosylcobalamin and the propionate metabolism for the conversion of the methylmalonyl coenzyme A to succinyl coenzyme A, propional coenzyme A to methylmalonyl coenzyme A to succinyl coenzyme A. So methylmalonyl coenzyme A is the needed thing जो प्रोपियोनाइल कोएंजाइम को सक्सिनाइल कोएंजाइम ए में कन्वर्ट करेगा. Lack of adenosyl B12 lead to the large increase in the levels of methylmalonyl coenzyme A and its precursor propional coenzyme A, and this results in the synthesis of certain fatty acids which is incorporated into the neuronal lipids, and this biochemical abnormality may contribute to the neurogenic complications of the vitamin B12 deficiency, right? And yeah, so this is the main flow chart, and this is the methyl vitamin B12 or methylcobalamin, so that helps in the conversion of homocysteine to the methionine that we have discussed. Then this methyl THF will be getting converted to the THF, then this THF will be converted to the methylene THF, then DHF, and this is the thing जो कि hamper अगर हो गई, then DNA synthesis will be hampered, right? And this is due to the folate, and if the patient would be having vitamin B12 deficiency, then ये पूरा का पूरा pathway stop हो जाएगा, and if methyl THF will not converted to the THF, then ये पूरी cycle ही stop हो जाएगी. So thus vitamin B12 is necessary, and folic acid is also necessary. Then etiology and the classification of the megaloblastic anemia. So first of all, basically it is divided into three broad groups. First is vitamin B12 deficiency, then folate deficiency, and deficiency from other causes. So first of all, vitamin B12 deficiency. In the Western countries, deficiencies of the vitamin B12 is more commonly due to the pernicious anemia, like I have told earlier. Then the true vegetarians like traditional Indian Hindus and breastfed infants have dietary lack of vitamin B12. ये भी मैंने बात कर ली थी. Gastrectomy by lack of intrinsic factor, and the small intestine lesions involving distal ileum where the absorption of the vitamin takes place. So there may be a deficiency of vitamin. अगर इंट्रिंसिक फैक्टर जनरेट नहीं हो रहा तो भी विटामिन B12 की डेफिशिएंसी हो जाएगी, और जहाँ से एब्जॉर्ब हो रहा है वहाँ वो चीज़ ही अगर हमने निकाल दी गैस्ट्रेक्टमी करके, सो एब्जॉर्ब भी नहीं होगा, राइट? सो ये दो मेन कॉजेज भी हो सकते हैं. Then deficiency of the vitamin B12 takes at least 2 years to develop when the body stores are totally depleted. And then the folate deficiency. Folate deficiency is more often due to the poor dietary intake. Other causes include malabsorption syndrome, excess folate utilization like in pregnancy and other various disease states, chronic alcoholism, excess urinary folate loss. Folate deficiency arises more rapidly than vitamin B12 deficiency since the body stores of the folate are relatively low, which can last for up to 4 months only. Patients with tropical sprue are often deficient in both vitamin B12 and folate. Combined deficiency of the vitamin B12 and folate may occur from severe deficiency of vitamin B12 because of the biochemical interrelationship of the folate metabolism. Other causes, in addition to the deficiency of the vitamin B12 and folate, megaloblastic anemias may occasionally be induced by other factors unrelated to vitamin deficiency. These include many drugs which interfere with the DNA synthesis, acquired effects of the hematopoietic stem cells, and rarely congenital enzyme deficiencies. Then clinical features. Deficiency of the vitamin B12 and folate may cause following clinical manifestations which may be present singly or in the combination or varying severity. Then macrocytic megaloblastic anemia is the cardinal feature of the PBF, and glossitis is the typical finding, and patient would be having a smooth, beefy, red tongue. And neurological manifestations are also common because of the degeneration of the myelin, because myelin needs vitamin B12, and if this myelin is not there, myelin formation needs both vitamin B12 and folic acid, और अगर इन दोनों की deficiency हो गई, then myelin generation would not be possible and the patient will end up in neuropathy and other disorders. Vitamin B12 deficiency, particularly in the patients with of pernicious anemia, is associated with the significant neurological manifestations in the form of subacute combined degeneration of the spinal cord and peripheral neuropathy, while folate deficiency may occasionally develop neuropathy alone, and the underlying pathologic process consists of the demyelination of the peripheral nerves and the spinal cord and the cerebrum. Then the signs and the symptoms include numbness, paresthesia, weakness, ataxia, poor finger coordination, and diminished reflexes. Then others. In addition to the cardinal features, patient might have jaundice, angular stomatitis, purpura, melanin pigmentation, symptoms of malabsorption, weight loss, and anorexia. Right? And the laboratory findings. Now let's discuss about the laboratory findings. So A, general laboratory investigations of the anemia, which include blood picture, red cell indices, bone marrow findings, biochemical tests, and B, special tests to establish the cause of the megaloblastic anemia as to know whether it is due to deficiency of vitamin B12 or folate. So general laboratory investigation of the anemia, which include blood picture, red cell indices, bone marrow findings, biochemical tests. Then सेकेंड जो कि स्पेशल टेस्ट होते हैं, जो कि मैंने बताया था, स्केलिंग टेस्ट, एंड वी विल बी डिस्कसिंग मोर अबाउट इट. फर्स्ट इज ब्लड पिक्चर एंड रेड सेल इंडिसेस. ब्लड पिक्चर के अंदर हीमोग्लोबिन वुड बी इन नॉर्मल रेंज एंड रेड सेल्स वुड बी हैविंग अ मैक्रोसाइटोसिस, राइट. And microcytosis can also be seen in several other disorders like hemolysis, liver disease, chronic alcoholism, hypothyroidism, aplastic anemia, myeloproliferative disorders, reticulocytosis. And in addition, the blood smear demonstrates a marked anisocytosis, poikilocytosis, and presence of the macrovalocytes. Then basophilic stippling and occasional normoblasts may also be seen. And reticulocyte के अगर मैं बात करूँ, then reticulocyte count is generally low to normal in the untreated cases. Then now the absolute values of MCV, MCH and MCHC. The red cell indices reveal an elevated MCV above 120 FL proportionate to the severity of the macrocytosis, elevated MCH above 50 pg and normal or reduced MCHC. Leukocytes, the total WBC count that may be reduced. Presence of the characteristic hypersegmented neutrophils in the blood film should raise the suspicion of the megaloblastic anemia, and occasional myelocyte may also be seen here. Then platelet count may be moderately reduced to severely anemic patients. Bizarre forms of platelets may be seen. Then bone marrow findings. Marrow cellularity would be having hypercellular marrow with decreased myeloid erythroid ratio, because here erythroid hyperplasia would be there. Then erythropoiesis. There will be erythroid hyperplasia due to the characteristic megaloblastic erythropoiesis. Megaloblastics or megaloblasts are abnormal large nucleated erythroid precursors having nuclear cytoplasmic asynchrony, that is, the nucleus are less mature than the development of the cytoplasm, and the nucleus are large, having fine sieve-like open chromatin that stains lightly, while the hemoglobinization of the cytoplasm proceeds normally and at a faster rate, that is, a neuronal maturation lags behind that of cytoplasm because of the vitamin B12 deficiency, right? So I hope these things are understood to you all, and everything is fine, everything is going good, right? Should we proceed? Oh my god. Yeah. So granulocyte precursors are also affected at some extent, and the giant forms of the metamyelocyte and the band cells may be present in the marrow, and megakaryocytes are usually present in the normal number but may occasionally be decreased and show abnormal morphology such as hypersegmented nuclei and agranular cytoplasm, right? And marrow iron Prussian blue staining for marrow iron के लिए we do Prussian blue staining for iron in the marrow that shows an increase in the number and the size of the iron granules in the erythroid precursors. Ring sideroblasts are however rarely seen, but iron in the reticulum cell is increased. Then chromosomes. Marrow cells may show variety of the random chromosomal abnormalities such as chromosomal breaks, centromere spreading, etc. Then biochemical findings. In addition to the general blood and the marrow finding and the specific test to determine the cause of the deficiency, the following biochemical abnormalities are observed in the cases of the megaloblastic anemia, and there is rise in the serum unconjugated bilirubin and LDH as a result of ineffective erythropoiesis causing marrow cell breakdown. Then the serum iron and ferritin may be normal or elevated. Now comes the specific test, and in evaluating a patient of the megaloblastic anemia, it is very important to determine the specific vitamin deficiency by the assay of vitamin B12 and folate, and in sophisticated clinical laboratories, currently automated multi-parametric random access analyzers are employed based on the separation techniques by chemiluminescence and enzyme-linked fluorescence detection systems, which have been largely replaced the traditional microbiological assays that was Killing's test and serum vitamin B12 assay. So now what is used? Automated multi-parametric random access analyzers. So these are the technique So ये एक टेक्निक है, दिस इज अ टेक्निक दैट इज यूज नाउ डेज, एंड this access the vitamin B12 deficiency with the help of chemiluminescence and enzyme linked fluorescence detection, right, and thus they have replaced the Skilling's test and serum vitamin B12 assay. But we study Skilling's test because it is very important, and right, and first we will be doing serum vitamin B12 assay. So assay of the vitamin B12 in the blood can be done by two methods. First is microbiological assay and the second is radio assay. So microbiological assay, in this test the serum sample to be assayed is added in the medium containing all other essential growth factors required for a vitamin B12 dependent microorganism, and the medium along with the microorganism is incubated, and the amount of vitamin B12 is determined turbimetrically, which is then compared with the growth produced by a known amount of vitamin B12. And several organisms have been used for this test, such as Euglena gracilis, Lactobacillus leishmani, E. coli, Ochromonas, Malamensis, and E. gracilis is however considered more sensitive and accurate, and the addition of antibiotics to the test interferes with the growth and yields false low result. Then radioassay assays of the serum B12 by radioisotope dilution and the radioimmunoassay have been developed, and these tests are more sensitive and have an advantage over microbiological assays in that they are simpler, more rapid, and results are unaffected by antibiotics and other drugs which may affect the living organisms. Then Skilling's test, that is a 24-hour urinary excretion test. So Skilling test is done to detect the vitamin B12 deficiency as well as to distinguish and detect the lack of intrinsic factor and the malabsorption syndrome. So Skilling test is very necessary test. It helps to distinguish the cause, right? So अब देखते हैं कैसे करते हैं. So the result of the test also depends upon the good renal function and properly urinary collection. So radioisotope that is used is 58 cobalt and 57 cobalt, and the test is performed in 3 stages. Now फिर क्या हुआ था, stage 4 भी एक include कर दी थी. We will talk about this later. So stage 1 की बात करते हैं, without intrinsic factor. So in this the patient, after overnight fasting, it administered a oral dose of 1 mg of radioactive labeled vitamin B12, 200 ml of water, in 200 ml of water. So इसके अंदर हमने पेशेंट को सिर्फ एक जो रेडियो लेबल्ड vitamin B12 है वो दिया 200 ml, राइट, डिजॉल्व्ड इन 200 ml of water. प्लस हमने 1 mg ऑफ अनलेबल्ड वाइटामिन B12 भी दिया IM रूट से, बिकॉज वी वांट टू सैचुरेट द बाइंडिंग साइट्स ऑफ वाइटामिन B12 एंड वी वांट अ मोर amount of radioactive label to come out in the urine, right, so that we can assess, right. So अब क्या होगा, the patient is kept fasting for further period of 2 hours, following which urinary excretion of the B12 is estimated. In normal individuals, 24-hour urinary excretion is more than 10% of the oral dose of the hot B12, that is a radio labeled B12. Patients with intrinsic factor deficiency excrete a lower quantity of the hot B12 because more will be egested out in the feces, right, which is so यूरिन में कैसे आएगा विटामिन B12. देखो इस बात को समझना ज़रूरी है कि फर्स्ट ऑफ ऑल इंट्रिंसिक फैक्टर से एब्जॉर्ब हो गया, एब्जॉर्ब होने के बाद इफ योर बॉडी इज हैविंग excess of vitamin B12, then जो आपने extra लिया that will be just excreted out through urine, right. But if the patient is having intrinsic factor deficiency, then absorption will not be there, and if vitamin B12 is not absorbed, then the remaining vitamin B12 जो absorb नहीं हुआ that will come in feces, and feces को हम टेस्ट नहीं करें, we are testing urine. So the patient who will be having intrinsic factor deficiency would be having decreased urinary output of vitamin B12. Normal individual would be having a more urinary excretion, that is more than 10% of the oral dose of the radio labeled B12, right? Is it clear? Then now the second stage, stage 2. So in this we give with intrinsic factor. So if the 24-hour urinary excretion of the hot B12 is low, so it means that there may be intrinsic factor deficiency. So now we give artificial intrinsic factors with the B12. So the test is repeated using the same procedure as in the stage 1, but in addition, higher oral dose of intrinsic factor is administered along with the radio labeled B12, and now urinary 24-hour urinary excretion is assessed. And now what will we be seeing? If the patient is having intrinsic factor deficiency, then the urinary excretion will be high, right? And the patient would that are having pernicious anemia have abnormal test even after treatment with the B12 due to the intrinsic factor deficiency. However, abnormal 24-hour is further investigation in the stage 3 for the cause of intestinal malabsorption of the hot B12. So अगर अभी भी if vitamin B12 in the urine is coming low even after giving it with intrinsic factor, then patient might be having the malabsorption syndrome. So now we have to assess it in the stage 3. So stage 3 में test for the malabsorption of vitamin B12 is done. Some patients absorb vitamin B12 in water as was stipulated in the original Skilling's test. So now modified Skilling test employed the use of the protein bound vitamin B12, and in conditions causing malabsorption the test is repeated after a course of antibiotics or anti-inflammatory drugs. So now in the stage 4 what will happen? Stage 4 में आप पहले एंटीबायोटिक की थेरेपी दोगे इफ़ यू आर सस्पेक्टिंग एनी इन्फेक्शन, एनी गैस्ट्रो एंट्राइटिस एंड एनी अदर इन्फेक्शन जिसकी वजह से मैल एब्जॉर्प्शन हो रहा है, और एनी इन्फ्लेमेटरी डिसऑर्डर्स जिसकी वजह से मैल एब्जॉर्प्शन हो रहा है, राइट? सो वो उनकी रिस्पेक्टिव मेडिकेशन देकर, रिस्पेक्टिव थेरेपी देकर, देन यू विल बी गिविंग अस, then you will be following the same scenario. And if now test is normal, then you will be diagnosing that the patient is having the malabsorption syndrome and the etiology is this. So now you will be looking forward to the etiology, you will be treating the etiology first, and vitamin B12 deficiency will be subside on its own if you treat the disorder, or you will be adding supplementation of vitamin B12. So it's a very easy test, but main thing is concept, and I think you have built that concept in this session. And yeah, let's just move forward further. Now the serum enzyme levels. Besides Skilling test, another way to distinguish whether megaloblastic anemia is due to the cobalamin or folate is by serum determination of methyl malonic acid or homocysteine by sophisticated enzymatic assays. Both are elevated in the cobalamin deficiency, while in folate deficiency there is only elevation of the homocysteine and not of methyl malonic acid. And test for the folate deficiency. So now the normal range of the serum folate is 6 to 18 Ng per ml. Values of 4 Ng per ml or less are generally considered to be diagnostic of the folate deficiency. Measurement of the formiminoglutamate acid or FIGLU urinary excretion after histidine load was used formally for assessing the folate status, but it is less specific, less sensitive than the serum assays. Currently, there are 3 tests that are used to detect the folate deficiency and urinary excretion of the FIGLU and red cell folate and serum and red cell folate, right? So, urinary excretion of FIGLU. First, folic acid is required for the conversion of the FIGLU to glutamic acid in the catabolism of the histidine, right? Thus, an oral administration of histidine will be causing urinary excretion of figlu, right? And thus this is a diagnostic test. Then serum folate assay. The folate in serum can be estimated by two methods. First is microbiological assay and second is radio assay, same as vitamin B12. So microbiological assay के अंदर this test is based on the principle that the serum folate acid activity is mainly due to the presence of the folic acid coenzyme, that is 5-methyl THF, and that this compound is required for the growth of the microorganism Lactobacillus casei. And the growth of the Lactobacillus casei is inhibited by the addition of the antibiotics. And the second one, radioassay. The principles and the method of the radioassay by radioisotope dilution test are similar to that of the serum B12 assay, and the test employs labeled glutamic acid and methyl THF, and commercial kits are available which permit the simultaneous assay of both vitamin B12 and folic acid. Then red cell folate assay. Red cell contain about 20 to 50 times more folate than the serum. Thus, red cell folate assay is more reliable indicator for the tissue stores of the folate than the serum folate assay. And microbiological radioassay and protein binding assay method can be used for the estimation of the red cell folate. And red cell folate values are decreased in the patient with megaloblastic anemia as well as in the patients with the pernicious anemia. So red cell folate values are decreased in the patients of megaloblastic anemia and the pernicious anemia. Then the principle of the treatment. First of all, most cases of the megaloblastic anemia need therapy with appropriate vitamin. So this include hydroxycobalamin IM injection 1000 mg for 3 weeks and oral folic acid 5 mg tablet daily for 4 months. Severely anemic patient in whom a definite deficiency of either vitamin cannot be established with certainty are treated with both vitamin concurrently. Then a blood transfusion should be avoided since it may cause circulatory overload. Packed cell may however be infused slowly, and treatment of megaloblastic anemia is quite gratifying, and the marrow begins to revert back to normal morphology within a few hours of initiating treatment and becomes normoblastic within 48 hours of start of the treatment, and reticulocytosis appears within 4 to 5 days after therapy started and peaks at day 7. Then hemoglobin should rise by 2 to 3 gram per deciliter each fortnight, and peripheral neuropathy may show some improvement, but subacute combined degeneration of the spinal cord is irreversible. Right, so initially जैसे ही आपको पता चला you should start the treatment. Otherwise, if the subacute combined degeneration of spinal cord has been started, then it is irreversible disorder or damage. Then pernicious anemia. Pernicious anemia was first described by Edison, so that's why we call it as Edisonian's anemia. And it was a chronic disorder of middle-aged and elderly individual of either sex in which intrinsic factor secretion ceases owing to atrophy of the gastric mucosa, and the condition is therefore termed as Edisonian megaloblastic anemia. The average age of the presentation is 60 years, but rarely can be seen in the children as well under the 10 years of the age. That is called as juvenile pernicious anemia. Pernicious anemia is seen most frequently in the individuals of the Northern European descent and African Americans, and is uncommon in South Europeans and Orientals. Then pathogenesis. There is a evidence to suggest that the atrophy of the gastric mucosa in pernicious anemia resulting in absence or low level of intrinsic factor is caused by autoimmune reaction against the gastric parietal cells, and the evidences in support of the immunological abnormalities in the pernicious anemia are as under. First is the incidence of the pernicious anemia is high in the patients with other autoimmune diseases such as Graves' disease, myxedema, thyroiditis, vitiligo, diabetes, and idiopathic adrenocortical insufficiency. Patients with pernicious anemia have abnormal circulating autoantibodies such as anti-parietal cell antibody and anti-intrinsic factor antibody. Then relatives of the patient with pernicious anemia have an increased incidence of the disease or increased presence of the autoantibodies. Then corticosteroids have been reported to be beneficial in curing the disease both pathologically and clinically. And pernicious anemia is most common in the patient with A gamma globulinemia, supporting the role of cellular immune system in the destruction of the parietal cells. And certain HLA types have been reported to be associated with the pernicious anemia. Then the morphological features. The most characteristic pathological finding in the pernicious anemia is gastric atrophy, affecting the acid and pepsin secreted portion of the stomach and sparing the antrum. Gastric epithelium may show the cellular atypia. About 2 to 3% of pernicious anemia develop carcinoma of the stomach, and other pathological changes are secondary to the vitamin B12 deficiency and include the megaloblastoid alterations in the gastric and intestinal epithelium and neurological abnormalities such as peripheral neuropathy and spinal cord damage. Clinical features. The disease has insidious onset and progresses slowly. The clinical manifestations are mainly due to the vitamin B12 deficiency. These include anemia, glossitis, neurological abnormalities, neuropathy, subacute combined degeneration of spinal cord, retrobulbar neuritis, gastrointestinal manifestations such as diarrhea, anorexia, weight loss, dyspepsia, hepatosplenomegaly, congestive heart failure, hemorrhagic manifestations, and other autoimmune diseases such as autoimmune thyroiditis may be associated. Then the principles of the treatment. First of all, parenteral vitamin B12 replacement therapy. You cannot give oral therapy here because patient is deficient of intrinsic factor. So that's why you have to give a parenteral vitamin B12 replacement therapy. Then symptomatic and supportive therapy such as physiotherapy for neurological deficits and occasionally blood transfusion can also be given. Follow up for early detection of the cancer of the stomach, because around 2 to 3% are predisposed for the development of the carcinoma or C of the stomach. Most of the abnormalities due to the vitamin B12 deficiency can be corrected except the irreversible damage to the spinal cord. Corticosteroid therapy can improve the gastric lesion with the return of acid secretion, but the higher incidence of the gastric polyps and the cancer of the stomach in these patients can only be detected by frequent follow-up. Hemolytic anemia. So hemolytic anemia is itself a very huge topic. So now let's just do the hemolytic anemia. Wait a second. Yeah. So hemolytic anemias are defined as anemias resulting from the increase in the rate of cell destruction. So there is a increase in the cell destruction. Normally, if eat red cells undergo lysis at the end of their lifespan, that is 120 days, right? Within the cells of the RE system in the spleen, so basically the red cells, they die in spleen. So spleen is the graveyard for RBC. But they can also die extravascularly, and thus they can cause extravascular hemolysis, but not so much and not in normal individuals. And hemoglobin is not liberated into the plasma in appreciable amounts. So that's why it is not a problem in a physiological patient or in a normal patient. The red cell lifespan is shortened in the hemolytic anemia, that is, there is accelerated hemolysis, however shortening of the red cell lifespan, and basically shortening of the red cell lifespan does not necessarily result in anemia. There can be increased destruction. Hyperactive spleen can also cause hemolytic anemia. In fact, a compensatory bone marrow hyperplasia may cause 6 to 8 fold increase in the red cell production without causing any anemia to the patient, so called as compensated hemolytic disease. and two sides. The premature destruction of the red cell in the hemolytic anemia may occur at either of the following two sites. Firstly, the red cells undergo lysis in the circulation and release their contents into the plasma. That is called as intravascular hemolysis. And in these cases, plasma hemolysis rises substantially and it is excreted in urine and it will be causing hemoglobinuria. Secondly, the red cells are taken up by the cells of the RE system and they are destroyed there and digested, and they are causing extravascular hemolysis and they are giving rise to large amount of bilirubin, right? So first of all, in extravascular hemolysis, plasma hemoglobin level is therefore barely so plasma hemoglobin level will be normal. But extravascular hemolysis is more common than the former. One or more factors may be involved in the pathogenesis of the various hemolytic anemias. Clinically, hemolytic anemia may be acute or chronic, mild to severe, and hereditary to acquired. So first of all, we will be studying, so basically it is divided into two categories, acquired and hereditary. So acquired hemolytic anemias and the hereditary hemolytic anemias. So generally it is seen that acquired wala jo hai na, that will be causing a extra that will be of extrinsic environmental factors, and hereditary is usually the result of the intrinsic red cell defects. So let's just discuss it further. So this is the classification of the hemolytic anemia. It is taken from the Hirschman. So acquired antibody, first of all acquired के अंदर we will be talking about antibody. So autoimmune hemolytic anemia, drug induced immunohemolytic anemia, and isoimmune hemolytic anemia. So autoimmune hemolytic anemia, AIHA, is further divided into warm antibody autoimmune hemolytic anemia and cold antibody autoimmune hemolytic anemia. And mechanical trauma will be causing microangiopathic hemolytic anemia. Direct toxins, direct toxic effects like malaria, bacterial infection, sepsis, and other agents, they will be causing direct toxic effects on the red blood cells, and thus they will be causing hemolysis. Then acquired red cell membrane abnormalities like paroxysmal nocturnal hemoglobinuria and splenomegaly is other acquired cause of hemolysis. Then hereditary के अंदर abnormalities of the red cell membrane. First of all, hereditary spherocytosis, hereditary elliptocytosis, or hereditary ovelocytosis, hereditary stomatocytosis. So these all are hereditary conditions that will be causing hemolysis. Then there are few intrinsic defects that will be causing hemolysis. First of all is G6PD deficiency, that will be causing a defect in HMP shunt. Then pyruvate kinase deficiency, that will be having a defect in Embden-Meyerhof pathway. And then hemoglobinopathies, that will be sickle cell anemia, and reduced globin synthesis, that is thalassemia. So these all are the causes, or you can say classification of the hemolytic anemia. So now we will be starting from the acquired and we will be doing antibody wala part, immunohemolytic anemias, and we will be doing autoimmune hemolytic anemia, AIHA. So first of all, general clinical features क्या होते हैं hemolytic anemia के? First of all is presence of the pallor of the mucous membranes. So this is the same common feature of all the anemia. Positive family history with the lifelong anemia in the patient with congenital hemolytic anemia. Third one is mild fluctuating jaundice due to the unconjugated hyperbilirubinemia, because in the extravascular hemolysis all the heme will be converted to the bilirubin, and thus bilirubin will be causing jaundice. And then urine turns dark on standing due to the excess of the urobilinogen in urine. Right. Then splenomegaly is found in most of the chronic hemolytic anemias in both congenital and acquired, and because of the hypersplenectomized subjects के अंदर hemolytic anemia is common. Pigmented gallstones are found in some cases. So that's a secondary thing. pigmented gallstones is a secondary thing. It is not a primary thing. It will not cause hemolytic anemia. Pigmented gallstones will never cause a hemolytic anemia, right? uh, Hemolytic anemia will be causing pigmented gallstones. Why? How? Because if there is extravascular hemolysis, so RBCs will be broken down. RBCs टूटे, RBC का जो हीम है will be converted to bilirubin. Then this bilirubin will be in excess amounts, and as your bilirubin is in the excess amounts, in the larger amount, so that will give rise to the gallstones, and your gallstones will be pigmented. Otherwise the gallstones are white, translucent or yellowish, because gallstones are due to cholesterol. Generally gallstones are due to cholesterol deposition. So the patient who is having higher LDL or dyslipidemia like conditions will be having or will be predisposed to form the gallstones, and the gallstones that are arised from the fat will be looking like fat. They will be of a off-white color, white, yellowish color. But here you will be getting pigmented gallstones because of the bilirubin, right? So it is a secondary effect. So laboratory evaluation of the hemolysis. So test of the increased red cell breakdown. First is serum bilirubin. So serum bilirubin के अंदर your unconjugated bilirubin will be raised because of the extravascular hemolysis. Urine urobilinogen will be raised, but there will be no bilirubinuria. Then fecal stercobilinogen will also be raised. Serum haptoglobulin is reduced or absent. Then plasma lactic dehydrogenase is raised, and evidences of the intravascular hemolysis in the form of hemoglobinemia, hemoglobinuria, methemoglobinemia and hemosideruria will be present. So intravascular में hemoglobinemia and hemoglobinuria will be common thing, right? Then the test of the increased red cell production. Red cell count reveals reticulocytosis, which is generally early and is hence most useful initial test of marrow erythroid hyperplasia. Then second one is routine blood film shows macrocytosis, polychromasia and presence of the normoblasts. Then third, bone marrow shows erythroid hyperplasia with usually raised iron stores. Then fourth, X-ray of bone shows evidence of the expansion of the marrow space, especially in the tubular bones and skull. Then third, test of damage to the red cells. So first is PBF, peripheral blood smear में you will be seeing schistocytes that will be broken RBCs, so वो visible होंगे. That is the characteristic feature of hemolysis. Then osmotic fragility will be decreased, right? Then autohemolysis test with or without addition of glucose. Coombs antiglobulin test will test the damage to the RBC. Electrophoresis for abnormal hemoglobins. Then estimation of the HbA2, estimation of the HbF, test for the sickling, screening for the G6PD deficiencies and other enzymes. Example, Heinz bodies test. Then test for the shortened red cell lifespans. A shortened red cell survival is best tested by the 51 chromium labeling method. Normal RBC lifespan is around 120 days and it is shortened to 20 to 40 days in moderate hemolysis and 5 to 20 days in severe hemolysis. Then now let's talk about the acquired hemolytic anemias. So acquired hemolytic anemias are caused by a variety of the extrinsic factors, namely antibody. First is antibody, that is immunohemolytic anemia. Immunohemolytic anemia is further divided into hot and cold, warm and cold. Then mechanical factors, microangiopathic hemolytic anemias. Then direct toxic effects like malaria, clostridial infections, bacteremia, sepsis and all. then splenomegaly, then acquired membrane abnormalities like paroxysmal nocturnal hemoglobinuria. So these are the few causes or etiologies of the acquired hemolytic anemias. So let's talk about the immunohemolytic anemias. So immunohemolytic anemias are a group of the anemias that are occurring due to the antibody production by the body against its own red cells. So immunohemolytic anemia are a group of anemias occurring due to antibody production by the body against its own red cells. So our body is damaging its own RBCs. First is autoimmune hemolytic anemia, that is characterized by the formation of the autoantibodies. First is warm antibody autoimmune hemolytic anemia, in which the autoantibodies are reactive at the body temperature, that is 37 degrees Celsius, and cold antibody AIHA or autoimmune hemolytic anemia, in which the autoantibodies react better with the patient's own red cells at 4 degrees Celsius. सो कोल्ड वाली कोल्ड पे कोल्ड टेम्परेचर्स पर एक्टिवेट होगी, वार्म वाली वार्म टेम्परेचर्स पर एक्टिवेट होगी. Then direct induced immunohemolytic anemia, drug induced hemolytic anemias, then isoimmune hemolytic anemias, in which the antibodies are acquired by the blood transfusions, pregnancies, hemolytic disease of the newborn. And an important diagnostic tool in all the cases of immunohemolytic anemia is Coombs antiglobulin test for the detection of the incomplete Rh antibodies in the saline directly or after addition of the albumin. देन ऑटोइम्यून hemolytic anemia स्टार्ट करते हैं. वार्म एंटीबॉडी AIHA पैथोजेनेसिस. वार्म एंटीबॉडी इज रिएक्टिव एट द बॉडी टेम्परेचर एंड कोटिंग द रेड सेल्स आर जनरली IgG class antibodies and occasionally they are IgA. Right, they are IgA. Human red cells coated with IgG antibodies are bound to the surface of the RE cells and especially splenic macrophages, and a part of the coated cell membrane is lost, resulting in the spherical transformation of the red cells, that is acquired spherocytosis. Red cells coated with IgG along with C3 on the surface further promotes this red cell leukocyte interaction, accounting for more severe hemolysis. The spleen is particularly efficient in trapping the red cell coated with IgG antibodies, and it is thus the major site of red cell destruction in warm antibody AIHA. Then clinical features. Warm antibody AIHA may occur at any age and in either male and female. The disease may occur without any apparent cause, idiopathic, but about a quarter of the patient develop this disorder as a complication of the underlying disorder of the immune system, that is SLE, chronic lymphocytic leukemia, lymphomas, and certainly drugs such as methyl dopa and penicillin. Then chronic anemia of varying severity with remission and relapses, and splenomegaly, right? Then laboratory findings. So there are many hematological and biochemical findings. First is mild to moderate chronic anemia, reticulocytosis, prominent spherocytosis in the peripheral blood film, positive direct Coombs test, positive indirect Coombs test, unconjugated hyperbilirubinemia, coexistent immune thrombocytopenia, along with occasional venous thrombosis that may be present, and it is termed as Evans syndrome. And in more severe cases, hemoglobinemia and hemoglobinuria may be present. Then treatment of these cases consists of the removal of the cause whenever present and corticosteroid therapy, and in severe cases blood transfusion splenectomy is the second line of the therapy in this disorder. Then cold antibody AIHA pathogenesis. Antibodies which are reactive in the cold temperatures, that is 4 degrees Celsius, may induce hemolysis under two conditions: cold agglutinin disease and paroxysmal cold hemoglobinuria. Cold agglutinin disease. In cold agglutinin disease, the antibodies are IgM type, which bind to the red cells best at 4 degrees Celsius. These cold antibodies are usually directed against the first antigen on the red cell surface, and agglutination of the red blood cells by IgM cold agglutinins is most profound at very low temperature, but upon warming to 37 degrees Celsius or above, and this agglutination occurs quickly. Hemolytic effect is mediated through the fixation of the C3 to the red cell surface, and not by agglutination alone. Most cold agglutinins affect juvenile red blood cells, and the etiology of the cold antibody remains unknown, and it is seen in the course of certain infections, example mycoplasma, pneumonia, infectious mononucleosis, and in lymphomas. And paroxysmal cold hemoglobinuria in PCH cold antibodies and IgG antibody, which is directed against P blood group antigen and brings about complement mediated hemolysis. And attacks of PCH are precipitated by exposure to cold, and PCH is uncommon and may be seen in association with the tertiary syphilis or as a complication of certain infections such as mycoplasma, pneumonia, flu, measles, and mumps. Right? And clinical features, clinical manifestations are due to hemolysis and not due to agglutination. So first is chronic anemia, which is worsened by the exposure to cold. So whenever a patient will be going to a temperature that is 4 degrees Celsius or low, then he or she will be developing chronic anemia. Right? Then Raynaud's phenomena. So Raynaud's phenomena is a vasospastic phenomena that we will be discussing in today's session only, where we will be studying blood vessels. And today we will be starting with systemic pathology. So that is the first topic for systemic pathology, and that is the first session of the systemic pathology, and in that session we will be discussing about the Raynaud's phenomena. Then cyanosis affecting the cold exposed regions such as tips of the nose, ears, fingers, and toes. Then hemoglobinemia and hemoglobinuria occur on the exposure to cold. Then laboratory findings. So the hematologic and the biochemical findings are somewhat similar to those found in warm antibody IHA, except in the thermal amplitude. These findings are as follows: chronic anemia, low reticulocyte count since young red cells are affected more, spherocytosis is less marked, positive direct Coombs test for the detection of C3 on the red cell surface, but IgM responsible for C3 coating on the red cells is not found, and the cold antibody titer is very high at 4 degrees Celsius and is very low at 37 degrees Celsius. That is Donat-Landsteiner test. IgM class cold antibody has specificity for I antigen, and while the rare IgG class antibody for PCH has P blood group antigen specificity. Then treatment consists of keeping the patient warm and treating the underlying cause. Then this is the condition that predisposes to the autoimmune hemolytic anemia. So basically this slide shows the etiology or the causes. First is worm antibody autoimmune hemolytic anemia. So first is idiopathic, not known. Then second is lymphomas, leukemias, non-Hodgkin's lymphoma, CLL, Hodgkin's lymphoma. Then third, collagen vascular diseases like SLE, and drugs, that is methyl dopa, penicillin, quinidine, and post-viral also, because sometimes etiologies might be, or pathogenesis might be of mimicry or cross reactivity. So post-viral to most common pathogenesis would be that. And cold antibody autoimmune hemolytic anemia के अंदर cold agglutinin disease, first is acute, second is chronic. So acute के अंदर mycoplasma infectious और infectious mononucleosis, and chronic के अंदर idiopathic and lymphomas. Then PCH mycoplasma infections and viral flu, measles, mumps, and syphilis. Then the drug induced immunohemolytic anemia. So the drugs that are that causes the immunohemolytic anemia, first is alpha methyl dopa type antibodies. So a small population of the patients receiving a alpha methyl dopa develop immunohemolytic anemia, which is identical in every aspect to the warm antibody AIHA. that we have discussed above. Penicillin induced immunohemolysis. Patients receiving large doses of penicillin or penicillin type antibiotics develop antibodies against the red cells, and it forms a red cell drug complex, and thus when it goes to the uh, spleen induces hemolysis. Then innocent bystander hemolysis. So the drugs such as quinidine form a complex with plasma proteins to which an antibody forms. And the drug plasma protein antibody complex may induce lysis of the bystanding red blood cells or the platelets. So इसके अंदर red blood cell का कोई भी प्रॉब्लम नहीं हो रही, बट फिर भी रेड ब्लड सेल ही अफेक्ट हो रही है, because they are just because RBCs प्लाज्मा प्रोटीन्स के साथ हैं और ब्लड में प्लाज्मा प्रोटीन और ड्रग का एंटीबॉडी कॉम्प्लेक्स बन गया, और उसकी वजह से जो आसपास वाली चीज़ें हैं वो अफेक्ट हो रही हैं. सो दैट्स वाई इसका नाम है इनोसेंट बायस्टैंडर इम्यूनोहिमोलिसिस. Then in each type of drug induced immunohemolytic anemia, discontinuation of the drug results in the gradual disappearance of the hemolysis. So yeah, because noxious hemolysis is drug, so अगर drug की वजह से है then just stop the drug therapy. Isoimmune hemolytic anemia. Isoimmune hemolytic anemia are caused by acquiring the isoantibodies and alloantibodies by blood transfusions, pregnancies, and in hemolytic diseases of the newborn. These antibodies produced by one individual and are directed against red blood cells of the other. Microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia is caused by the mechanical trauma to the red cell in circulation and is characterized by the red cell fragmentation. And there are three different ways by which microangiopathic hemolytic anemia results. And external impact क्या आएगा? Direct external trauma to the red blood cells when they pass through the microcirculation, especially over the bony prominences, may cause hemolysis during various activities. Example in prolonged marchers, joggers, karate players. These patients develop hemoglobinemia, hemoglobinuria, and somewhat myoglobinuria as a result of damage to muscles. Then cardiac hemolysis. A small proportion of the patients who receive prosthetic cardiac valves or the artificial grafts develop hemolysis. This has been attributed to direct mechanical trauma to the red cells or shear stress from turbulent blood flow. Then fibrin deposit in microvasculature. So deposition of the fibrin in the microvasculature exposes the red cells to physical obstruction and eventually fragmentation of the red cells and the trapping of the platelets. So fibrin deposits in the small vessels may occur in the following conditions. First is abnormalities of the vessel wall, example in hypertension, eclampsia, disseminated cancers, transplant rejection and hemangioma. Then the second one is thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, and vasculitis in collagen diseases. Then hemolytic anemia from direct toxic effects. So hemolysis may result from the direct toxic effects of the certain agents. First is malaria by direct parasitization of the red cells that will be causing hemolysis or breakdown of the red cells. Then if the patient is having G6PD deficiency, then अगर आप उसको ऑक्सीडेंट ड्रग्स दे दो और ऑक्सीडाइजिंग ड्रग्स दे दो, then he might end up in black water fever, right? Then Bartonellosis by the direct infection of the red cells by the microorganism, septicemia with Clostridium welchi by damaging the red cells, other microorganisms such as pneumococci, staphylococci, E. coli. Then copper by direct hemolytic effect on red cells in the Wilson disease and patients on hemodialysis. Lead poisoning shows basophilic stippling of the red blood cells. Snake and spider bites cause hemolysis by their venoms. And extensive burns. So these are the few causes, few direct toxic effects of the certain noxious agents that causes hemolytic anemia. सो नाउ मेरा फ़ोन इज़ डिस्चार्ज एंड मैं एक बार फ़ोन बस चार्जिंग पे लगा के आता हूँ एंड वील बी कंटिन्यूइंग फर्दर. चार्जर इधर तो नहीं क्या, आई एम सॉरी बट चार्जर लाना पड़ेगा बिकॉज लाइव चैट मैं नहीं देख पा रहा और ये लगभग हाफ एन आवर से बंद हो गया है. सो वेट अ सेकेंड. सो गाइस, पेरोक्सिसोमल नॉकटर्नल हीमोग्लोबिनूरिया. एक बार लाइव चैट देख लेते हैं, उसके बाद आगे बढ़ेंगे. Why it is not switching on हो जा. Wait few more seconds guys. few more seconds. few more seconds. बस एक बार ये ऑन हो जाए. ऐसा तो कभी नहीं हुआ यार. What's wrong with this? Why is it not charging? I think because of the temperature. Let's leave it here and I think we should start. But ऐसा तो कभी भी नहीं हुआ है. So guys, peroxisomal nocturnal hemoglobinuria, PNH. PNH is a rare acquired disorder of the red cell membrane in which there is chronic intravascular hemolysis. So peroxisomal nocturnal hemoglobinuria. Hemoglobinuria is due to the intravascular hemolysis, right? So PNH is a rare acquired disorder of the red cell membrane in which there is a chronic intravascular hemolysis due to the sensitivity of the red blood cells to the complement due to the defective synthesis of the red cell membrane proteins. The defect affects all the cell of myeloid progenitor lineage, that is RBC, WBC and platelets, suggesting a deficient hematopoiesis, and the disorder generally presents in the adult life. So पैथोजेनेसिस क्या होता है इसका? पैथोजेनेसिस बहुत ही ज़्यादा इंपॉर्टेंट है समझना एंड दिस इज़ द वेरी क्रूशियल थिंग टू अंडरस्टैंड हियर. एंड फोन बस ऑन हो गया है एंड या वेट अ सेकेंड एंड या बस एक सेकेंड और. Connected to Wi-Fi. Let's open this back. Yeah. We are there. Yeah. Yes. we should keep this session till 10, or we can move it to 12 to 11 as well. Yeah, now I think we should carry on. Yes. So guys, everything is clear now. Is there any problem, any doubt? So if you are having any doubt, then just पूछ लो बस फटाफट से, and then we will just moving further and we'll be completing the things. So no doubts. I think you all are having no doubt, and yeah, we should start again. Yeah, we should start again. Now I think we should start again. Yeah. So pathogenesis. So guys, PNH is considered as an acquired clonal disease of the cell membrane, while a normal clone also continues to proliferate, and the defect is a mutation in the stem cells affecting the myeloid progenitor cells that is normally required for the biosynthesis of the glycosyl phosphatidyl inositol essentials for anchoring of the cells. The mutant form of the gene is an X-linked gene, and that is called as PIGA, phosphatidyl inositol glycan. Thus, as a result of mutation, there is a partial or complete deficiency of anchor protein. Then out of about 20 such proteins described so far, the lack of two proteins, decay decay acceleration factor and the membrane inhibitor reactive lysis, makes the RBC unduly sensitive to the lytic effect of the complement. Since PNH is the stem cell disorder and it may be accompanied with other stem cell disorders such as aplastic anemia. Oh my god. Oh my god. Yeah. So out of about 20 such proteins described so far, the lack of the two of the proteins, decay accelerating factor and the membrane inhibitor of the reactive lysis, makes the RBC unduly sensitive to the lytic effect of the complement. Since PNH is a stem cell disorder, it may also be accompanied with other stem cell disorders such as aplastic anemia and myelodysplastic syndrome. Right. And clinical and the laboratory findings are: first is hemolytic anemia, second one is pancytopenia, this we have discussed earlier, intermittent clinical hemoglobinuria, acute hemolysis episode occur at night because peroxisomal nocturnal hemoglobinuria. So night, identified by the passage of a brown urine in the morning. Then hemosideruria is very common. Venous thrombosis is also a common complication. Then the presence of inordinate sensitivity of the red blood cells, leukocytes and platelets to complement in PNH can be demonstrated by in vitro by ham's test using red cell lysis at the acidic pH, or by the sucrose hemolysis test, and about 20% of causes PNH, and they may develop myeloproliferative and myelodysplastic disorders, and some even develop acute myeloid leukemia. Then hemolytic anemia or splenomegaly. So hemolytic anemia is common in splenic enlargement from any cause. Normally, the spleen acts as filter and traps the damaged red blood cells and destroys them, and the splenic macrophages phagocytose the damaged red cells. The normal spleen poses no risk to normal red blood cells, but splenomegaly exaggerates the damaging effect to which the red cells are exposed. Besides the hemolytic anemia, splenomegaly is usually associated with pancytopenia. Then splenectomy, reduction in the size of spleen by appropriate therapy, relieves the anemia as well as improves the leukocyte and platelet counts. Right. The hereditary hemolytic anemias. Hereditary hemolytic anemias are usually the result of intracorpuscular defects. Accordingly, they are broadly classified in two groups. First is hereditary abnormalities of the red cell membrane, and B, hereditary disorders of the interior of the red cells. So hereditary abnormalities of the red cell membrane and hereditary disorder of the interior of the red cells. Hereditary abnormalities of the red cell membrane. So let's do this first. So the abnormalities of the red cell membrane are readily identified on the blood film examination, and there are three important types of the inherited red cell membrane defects. So first is hereditary spherocytosis, hereditary elliptocytosis, hereditary stomatocytosis, right? Then hereditary spherocytosis. It is a common type of hereditary hemolytic anemia of autosomal dominant inheritance in which the red cell membrane is abnormal. Right. Then pathogenesis. The molecular abnormality in the hereditary spherocytosis is a defect in protein which anchor the lipid bilayer to the underlying cytoskeleton. Then spectrin deficiency. Almost all cases have deficiency in the structural protein of the red cell membrane, spectrin. The spectrin deficiency correlate with the severity of the anemia. Then mutation in the spectrin by recessive inheritance causes A spectrin or alpha spectrin and causes more severe form of anemia, while mutation by dominant inheritance forming beta spectrin result in the mild form of the disease. Then enchirine abnormality. About half of the cases of the hereditary spherocytosis have defect in the enchirine, protein that binds protein 3 and spectrin. Homozygous state with recessive inheritance pattern has a severe anemia, while heterozygous with more common dominant inheritance pattern have milder anemia. Then inherited mutation in spectrin and enchirine causes defect in anchoring of the lipid bilayer cell membrane. So a red cell with such unstable membrane but with normal volume, when released in the circulation, lose their membrane further. Till they can accommodate the given value, the result in the formation of the spheroidal contour and the smaller size of the red blood cells termed microspherocytes. These deformed red cells are not flexible. Unlike normal biconcave red cells, these rigid cells are unable to pass through the spleen, and in the process they lose their surface membrane further. This produces a subpopulation of the hyperspheroidal red cells in the peripheral blood, which is subsequently destroyed in the spleen. Then anemia is mild to moderate. Splenomegaly is constant feature. Jaundice occurs due to the increased concentration of unconjugated bilirubin in the plasma. Pigment gallstones are frequent due to the increased bile pigmentation production, and splenectomy offers the only reliable mode of treatment, because due to splenomegaly there can be hemolysis, because spleen captures and breaks. Right. And laboratory finding. So anemia is mild to moderate. Reticulocyte is usually 5 to 20%. Blood film shows characteristic abnormality of the erythrocytes in the form of microspherocytosis. MCV is usually normal or slightly decreased in MCH is decreased, but MCH is increased. Osmotic fragility test is helpful in testing the spheroidal nature of the red cells, which lies more readily in solution of low salt concentration, that is osmotic fragility is increased. Then autohemolysis test. Autohemolysis test is similar to the osmotic fragility test after incubation and shows increased spontaneous autohemolysis as compared to the normal red cells. Autohemolysis is correctable by addition of the glucose. Then direct Coombs. Direct Coombs test is negative so as to distinguish this condition from the acquired spherocytosis of AIHA, in which the case is it is positive. So in that right now we have studied that their Coombs test was positive. Spherocytes may also be seen in the blood film in acquired immune hemolytic anemia following the red cell transfusion. Then hereditary elliptocytosis or hereditary ovelocytosis. Hereditary elliptocytosis or hereditary ovelocytosis is another autosomal dominant disorder involving the red cell membrane protein spectrin. Some patient may have inherited the defect in the erythrocyte membrane protein 4.1 that interconnects the spectrin with actin in the cytoskeleton, and the disorder is similar in all the respects to hereditary spherocytosis except that the blood film shows oval and elliptical red cells and is clinically a milder disorder than the hereditary spherocytosis. Acquired causes of elliptocytosis includes iron deficiency, myeloproliferative disorders, and stomatocytes. So this is a hereditary stomatocytosis. Stomatocytes are the cup shaped RBC. So इनके बीच में you can see a mouth like slit, it is present, and having one surface concave and other surface convex. So this is a concave surface and other convex. So this looks like a cup, and this looks like a mouth as well. So this causes a central slit-like or mouth-like appearance of the red cells. The underlying defect is in the membrane protein stromatin, having an autosomal dominant pattern of the inheritance, same as ovelocytosis or spherocytosis. The stomatocytosis are swollen red cells, overhydrated red cells due to the increased permeability to the sodium and potassium, and the affected patients have milder anemia and splenomegaly. Then hereditary disorders of the red cell interior, right? Inherited disorders involving the interior of the red blood cells are classified into two groups: red cell enzyme defects, enzymopathies. These cause defective red cell metabolism involving two pathways: defects in the hexose monophosphate and HMP shunt. Common example is glucose 6 phosphate dehydrogenase or G6PD deficiency. Then defect in Emden Meyerhoff glycolytic pathway, example PK deficiency. And then disorders of the hemoglobin or hemoglobinopathies. First is structurally abnormal hemoglobin, and second is reduced globin chain synthesis. Examples are sickle syndromes and other hemoglobinopathies, and common example is various types of thalassemia. Then G6PD deficiency. Among the defect in HMP shunt, the most common is G6PD deficiency. G6PD gene is located on the X chromosome, and its deficiency is therefore a sex X-linked trait affecting males, and females are the carriers and asymptomatic. Several variants of G6PD have been described. The normal G6PD variant is designated as a type B, but blacks have normally A positive type G6PD variant, and the most common and the significant clinical variant is A negative type found in black males, like the HBS gene. The A type G6PD variant confers the protection against the malaria, and individuals with the A-type G6PD variant have shortened lifespan but without anemia. However, these individuals develop hemolytic episodes and on exposure to oxidant stress such as viral and bacterial infections, certain drugs, anti-malarial sulfonamides, nitrofurantoin, aspirin, vitamin K, metabolic acidosis, and on ingestion of the fava beans or favism. Then pathogenesis. Normally red blood cells have well protected against oxidant stress because of the adequate generation of the reduced glutathione via the HMP shunt, and individuals with inherited deficiency of G6PD and enzyme required for HMP shunt for glucose metabolism, so they fail to develop adequate levels of the reduced glutathione in the red cells, and this results in the oxidation and precipitation of the hemoglobin within the red cells, forming the Heinz bodies. And thus, besides the G6PD deficiency of the various other enzymes involved in the HMP shunt may infrequently cause clinical problems, and thus hemolysis. So acute clinical manifestation के अंदर acute hemolytic anemia. This develops in males, being X-linked disorders within hours of the exposure to the oxygen stress, such as drugs like primaquine infection, favism, injection of faba beans, and metabolic acidosis. The hemolysis is, however, self-limiting even if the exposure to the oxidant is continued, since it affects the older red cells only. Hemoglobin level may return to normal when the older population of the red cells have been destroyed and only younger cells remain. Then some patient may have only darkening of the urine from the hemoglobinuria, but more severely affected ones develop constitutional symptoms including jaundice. Then chronic hemolytic anemia के अंदर cases having severe enzyme deficiency have chronic persistent hemolysis throughout the life. Then neonatal jaundice. Infants born with G6PD deficiency may continue to have unconjugated hyperbilirubinemia and may even develop kernicterus. Then laboratory finding. During the period of acute hemolysis, there is rapid fall in the hematocrit by 25% to 30%, and features of the intravascular hemolysis such as rise in the plasma hemoglobin, hemoglobinuria, rise in unconjugated bilirubin, and fall in plasma heptoglobulin. Formation of the Heinz bodies is visualized by the means of supravital stains such as crystal violet, also called as Heinz bodies. Hemolytic anemia. However, Heinz bodies are not seen after the first 1 or 2 days, since they are removed by the spleen and leading to the formation of the white cells or the fragmented red cells. Then between the crisis, the affected patient generally has no anemia. The red cell survival is, however, shortened, and the diagnosis of the G6PD enzyme deficiency is made by one of the screening tests, that is methemoglobin reduction test (MRT), fluorescent screening test, ascorbate cyanide screening test, or by direct enzyme assay on the red cells. Then the treatment is directed towards the prevention of the hemolytic episodes, such as stoppage of the offending drug. Blood transfusion are rarely indicated. Right? Wait a second. So now structural abnormal hemoglobins, that is sickle cell anemia, so or sickle syndromes. So in this you will be seeing this type of RBCs. So the most important and widely prevalent type of hemoglobinopathy, and it is due to the presence of the sickle hemoglobin in the red blood cells, and the red blood cells with HBS developing sickling when they are exposed to the low oxygen tension. Sickle syndrome have highest frequency in the black race and Central Africa, where falciparum malaria is endemic. So this is generally for the benefit. Patients with HBS are relatively protective against falciparum malaria. So sickle syndrome, they occur in 3 different forms. First is as heterozygous state, then homozygous, then as double heterozygous state. So first is heterozygous state for HBS, that is sickle cell trait. Then second one is homozygous state, that is sickle cell anemia. Then double heterozygous state, that is sickle B thalassemia, sickle C disease, sickle D disease. So this is a double heterozygous states, right? And heterozygous state की अगर मैं बात करूँ, that is the first one, that is the sickle cell trait. So sickle cell trait is a benign heterozygous state of HBS in which only one abnormal gene is inherited. Patients with AS develop no significant clinical problems except when they become severely hypoxic and may develop sickle cell crisis. Homozygous state, in the sickle cell anemia is a homozygous state of HBS in the red cells in which an abnormal gene is inherited from each parent. Then the double SS or the homozygous state is a severe disorder associated with the protean clinical manifestations and decreased life expectancy. So the laboratory findings. The patients have no anemia and have normal appearance of the red blood cells but in hypoxic crisis. So when O2 is decreased, the hemoglobin gets converted to granules, and this ultimately converts the normal RBC to sickle cell RBC. So sickle cell crisis develops, and the diagnosis is made by two tests. First is demonstration by sickling, done under condition of reduced oxygen tension by an oxygen consuming reagent sodium metabisulfite. Hemoglobin electrophoresis reveals 35 to 40% of the total hemoglobin as HbS. Then pathogenesis. Basic molecular lesion, that is in HbS. Basic genetic defect is the single point maturation in one amino acid out of 146 in hemoglobin molecule, and there is substitution of valine for glutamic acid at 6 residue position of the beta globulin, producing the HbA2B2S, alpha 2 beta 2S. Then second mechanism of sickling, during the deoxygenation or reduced oxygen, a red cell containing the HbS change from the biconcave disc shape to the elongated crescent shape or sickle shape. This process is termed as sickling and occurs both within the intact red cells and in vitro in the free solution. And the mechanism responsible for the sickling upon deoxygenation of HbS containing the red cells is the polymerization of the deoxygenated HbS, which aggregates to form the elongated rod-like polymers, and these elongated fibers align and distort the red cell into classic sickle shape. The reversible and irreversible sickling. So the oxygen dependent sickling process is usually reversible. However, the damage to the red cell membrane leads to formation of the irreversibly sickled red cells even after they are exposed to normal oxygen tension. Then 4. Factor determining the rate of sickling. So following factor determine the rate of the polymerization of the HbS and consequent sickling take place. First is the presence of non-HbS hemoglobin. So in the red cell in the patient with SS have the predominance of the HbS and small part of non-HbS. So thus chiefly HbF, so HbS अगर ज़्यादा है तो सिकलिंग बहुत ही ज़्यादा प्रेवलेंट होगी, राइट. देन इंट्रासेलुलर कॉन्सेंट्रेशन ऑफ HbS, इंट्रासेलुलर कॉन्सेंट्रेशन ऑफ HbS अगर ज़्यादा है, देन टोटल हीमोग्लोबिन कॉन्सेंट्रेशन, एक्सटेंट ऑफ डीऑक्सीजनेशन, कितनी ऑक्सीजन बिल्कुल कम हो गई तो बहुत ही ज़्यादा प्रेवलेंट सिकलिंग होगी. एसिडोसिस एंड डिहाइड्रेशन के टाइम भी and increased concentration of 2,3 BPG in the red cells. So now comes the clinical features. First is anemia. Anemia तो दिखेगा, and there is usual severe chronic hemolytic anemia with onset of aplastic crisis in between, and the symptoms of the anemia are generally mild, since HbS gives up oxygen more readily than HbA to the tissues. Second one is vaso-occlusive phenomena. Patients of SS develop recurrent vaso-occlusive episodes throughout their lives due to the obstruction to the capillary blood flow by sickled red blood cells upon deoxygenation and dehydration. Vaso-obstruction affecting different organs are the tissues resulting in the infarcts, which may be of two types. First is microinfarct, second is macroinfarct. So microinfarct affecting particularly the abdomen, chest, back, joint, and are the causes of recurrent painful crisis in the SS. Then macroinfarct involves most commonly the spleen, splenic sequestration, autosplenectomy, bone marrow pains, bones aseptic, necrosis, osteomyelitis, lungs, pulmonary infection, kidney, renal, cortical necrosis, CNS में stroke, retinal damage, skin ulcers, and result in the anatomic and functional damage to these organs. Then constitutional symptoms. In addition to the features of anemia and infarction, patients with SS have impaired growth and development and increased susceptibility to the infection due to the markedly impaired splenic function. Right. Then reduced globin chain synthesis. Thalassemias. The thalassemias are the diverse group of hereditary disorders in which there is reduced synthesis of one or more of the globin polypeptide chains. Thus, thalassemia, unlike hemoglobinopathies, which are qualitative disorders of hemoglobin, are quantitative abnormality for the polypeptide globin chain synthesis. Then genetics and the classification. Thalassemias are the genetically transmitted disorders. Normally, an individual inherits two beta globin chain, located on the two chromosomes, and two alpha globin gene, one each on the two chromosomes 16. So beta globin is located on the chromosome 11, and alpha globin gene is located on the chromosome 16 from each parent, that is normal adult hemoglobin HbA alpha to beta 2, depending upon whether the genetic defect or deletion lies in the transmission of alpha or beta globin chain genes. Thalassemia are classified into alpha and beta thalassemias. Thus, the patient with alpha thalassemia have structurally normal alpha globin chains, but the production is impaired. Similarly, in beta globin chains are structurally normal, but their production is decreased. And each of the two main type of the thalassemia may occur as a heterozygous, that is called as alpha and beta thalassemia minor trait, or homozygous, that is major alpha and beta thalassemia major. And the former is generally asymptomatic, so a minor will be generally asymptomatic, but the major one is severe congenital hemolytic anemia. Then pathophysiology of the anemia in thalassemia. So a constant feature of all the forms of thalassemia is the presence of the anemia, which forms the following mechanism. So alpha thalassemia. In the alpha thalassemia major, the obvious cause of the anemia is the inability to synthesize the adult hemoglobin. While in the alpha thalassemia trait, there is reduced production of the normal adult hemoglobin. And in beta thalassemia major, the most important cause of the anemia is premature red cell destruction brought about by erythrocyte membrane damage caused by the precipitated alpha globin chains. Other contributory factors are shortened red cell lifespan, ineffective erythropoiesis, hemodilution due to the increased plasma volume, and a deficiency of the beta globin chains in the beta thalassemia leads to the large excess of a chain within developing red cells. Part of these excessive alpha chains are removed by pairing with the gamma globin chains as HbF, while the remainder unaccompanied alpha chains precipitate rapidly, and thus they cause or they form Heinz bodies. Then the precipitated alpha chain, they cause red cell membrane damage during their passage through the splenic sinusoids. These red cells are further damaged and develop pitting due to the removal of the precipitated aggregates. Thus, such red cells are irreparably damaged and are phagocytosed by the RE cells of the spleen and the liver, causing anemia and hepatosplenomegaly and the excess of the tissue iron stores. The patients with beta thalassemia minor, on the other hand, have a very mild ineffective erythropoiesis and hemolysis and shortening of the red cell lifespan. Right. And alpha thalassemia. So molecular pathogenesis. Alpha thalassemia are the disorders in which these are defective synthesis of the alpha globin chain, resulting in the depressed production of the hemoglobin that contain alpha chain, that is HbA, HbA2 and HbF. Then alpha thalassemia are most commonly due to the deletion of one or more of the alpha genes located on the shortened arm of the chromosome 16. Since there is a pair of alpha chain gene, the clinical manifestation of alpha thalassemia depend upon the number of the gene deleted. Accordingly, alpha thalassemia are classified in the four types: 4 alpha gene deletion, HB Bart's hydrops 2, 3 alpha gene deletion, HBH disease disorder, 2 alpha gene deletion, a thalassemia trait, and 1 gene deletion, 1 alpha gene deletion, that is thalassemia carrier or alpha thalassemia trait. And HB Bart's hydrops. When there is deletion of all the 4 alpha chains, it results into the total suppression of alpha globin chain synthesis, causing the most severe form of alpha thalassemia called as HB Bart hydrops. And HB Bart is a gamma globin chain tetramer, and which is having a high oxygen affinity, leading to severe tissue hypoxia. Right. So clinical features of hydrops. HB Bart hydrops is incompatible with life due to the severe tissue hypoxia and severe tissue hypoxia. What's wrong with this? Yeah. So severe tissue hypoxia, and thus what it will cause, the condition is either fatal in the uterus only, or the infant dies shortly after the birth. And if brought alive, the feature similar to severe RH hemolytic disorder, severe RH hemolytic disease are present. Then laboratory finding: infant with HB Bart hydrops born alive may have the following laboratory findings. First is severe anemia. Blood film show marked anisopoikilocytosis. Shape भी different होंगी और sizes भी different होंगे. Hypochromia, microcytosis, polychromasia, basophilic stipplings, numerous normoblasts and target cells. Reticulocyte count is high. Serum bilirubin level is elevated. Hemoglobin electrophoresis shows 80 to 90% of HB parts and a small amount of HBH and HB port length, but no HBA, HBA2 or HBF. Right. HBH disease. Deletion of the 3 alpha chain gene produces HBH, which is a beta globin chain tetramer. So and markedly impaired chain synthesis, and HBH is precipitated as Heinz bodies within the affected red cells and as elongated alpha chain variant of HBH disease termed as HB constant spring. Then clinical features: HBH disease is generally present as well as well compensated hemolytic anemia. The features are intermediate between the beta thalassemia minor and major, and the severity of the anemia fluctuates and may fall to very low levels during pregnancy or infections, and majority of the patients having splenomegaly or may develop cholelithiasis. Then laboratory findings: so moderate anemia, hemoglobin 8 to 9 gram per deciliter. Blood film show microcytosis, hypochromia, basophilic stippling, target cells, normoblast, mild reticulocytosis, Heinz bodies that can be demonstrated in mature red cells with brilliant crescile blue stain. Then hemoglobin electrophoresis shows 2 to 4% of HBH, and the remainder consists of HBA, HBA2 and HBF. Then alpha thalassemia trait. Alpha thalassemia trait may occur by the following molecular pathogenesis: by the deletion of the 2 of the 4 alpha chain gene in homozygous form called as homozygous alpha thalassemia, or in the double heterozygous form termed heterozygous alpha thalassemia; by the deletion of the single alpha chain gene causing heterozygous alpha thalassemia trait called as heterozygous alpha thalassemia. Then clinical features: alpha thalassemia trait due to the 2 alpha chain gene deletion is asymptomatic, and it is suspected in the patient of the refractory microcytic hypochromic anemia in whom iron deficiency and beta thalassemia have been excluded, and the patient belongs to the high risk of ethnic group, and 1 gene deletion of alpha thalassemia trait is a silent carrier state. And laboratory finding के अंदर the patient of alpha thalassemia traits show the following hematological findings. First is hemoglobin level normal or mildly reduced. Then blood film shows microcytic and hypochromic red cell morphology but no evidence of hemolysis or anemia. MCV, MCH, MCHC may be slightly reduced, and hemoglobin electrophoresis reveals small amount of Hb parts in the neonatal period which gradually disappears by the adult life. Then HbA2 is either normal or slightly decreased, right? And now comes the bleeding disorders or hemorrhagic diastasis. So we have completed the anemias, and now we will be starting right from the bleeding disorders or hemorrhagic diastasis, right? Let's just continue. So bleeding disorders or hemorrhagic diastasis are a group of disorders characterized by defective hemostasis and with abnormal bleeding, and the tendency of the bleeding may be spontaneous in the form of small hemorrhages of the skin and mucous membranes, example petechi, purpura, ecchymosis, and there may be excessive external or internal bleeding following the trauma and surgical procedures such as hematoma and hemarthrosis. Yeah. Right, and the causes of the hemorrhagic diastasis may or may not be related to the platelet abnormalities, because अगर मैं आपको बोलूँ कि bleeding spontaneous bleeding है, then आपका mind सीधा जाएगा thrombocytopenia की वजह से तो नहीं है. So they may or they may not be related to the platelet abnormalities. First is hemorrhagic diastasis due to the vascular abnormalities. Second is due to platelet abnormalities. And third is disorder of the coagulation factors. Fourth is hemorrhagic diastasis due to the fibrinolytic defects, and fifth is combination of all these as occurs in the disseminated intravascular coagulation. So vascular bleeding disorders, also called as non-thrombocytopenic purpura or vascular purpuras, are normally mild or characterized by petechi, purpura or ecchymosis and confined to the skin and mucous membranes. The pathogenesis of the bleeding is poorly understood since majority of the standard screening tests of the hemostasis include the bleeding time, coagulation time, platelet count, platelet function are usually normal. Vascular purpuras arise from the damage to the capillary endothelium and abnormalities to the subendothelial matrix or extravascular connective tissue that supports the blood vessel or from formation of the abnormal blood vessels. Vascular bleeding disorder may be inherited or acquired. So hereditary or inherited. Hereditary में Osler-Weber-Rendu disease. So this is a very good example, and this is a very uncommon inherited autosomal dominant disorder, and the condition begins in the childhood, and it is characterized as a abnormal telangiectatic dilated capillaries due to the vascular malformations in the skin and the mucosal surfaces, especially on the lips, tongue, nose, palms and soles. Clinically, patient present with the bleeding from the stomach, epistaxis from other mucosal surfaces as well. Then inherited disorders of the connective tissue matrix. So these include the Marfan syndrome, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, and all of which have inherited defect of the connective tissue matrix and thus have fragile skin vessels and easy bruising, right? And acquired vascular bleeding disorders, Henoch-Collins purpura. So the salient features of Henoch-Collins and anaphylactoid purpura are as under. First is, it is a self-limited type of hypersensitivity vasculitis occurring in the children and young adults. Second is, the hypersensitivity vasculitis produces purpuric rash on the extensor surface of the arm, leg and on the buttocks, as well as hematuria, colicky, abdominal pain due to the bleeding into the GIT, polyarthralgia and acute nephritis. In spite of these hemorrhagic features, all coagulation tests are normal. The vessel wall shows leukocytoclastic vasculitis as seen by viable and necrotic neutrophils. Circulating immune complexes are deposited in the vessel wall consisting IgA, C3 and fibrin, and in some cases propedrin suggesting activation of the alternating complement pathway as a triggered event. Then hemolytic uremic syndrome. Hemolytic uremic syndrome is a disease of infancy and early childhood in which there is a bleeding tendency and varying degree of acute renal disease or failure. The disorder remains confined to the kidney where hyaline thrombi are seen in the glomerular capillaries. Then simple easy bruising. So easy bruising of unknown cause is a common phenomena in women of childbearing age group, and many infections cause vascular hemorrhages either by causing toxic damage to the endothelium or by DIC. They are especially prone to occur in septicemia or severe measles. Then the drug reaction. Certain drugs form antibodies and produce hypersensitivity vasculitis responsible for the abnormal bleeding. Then steroid purpura. Long-term steroid therapy or the Cushing syndrome may be associated with the vascular purpura due to the defective vascular support. Then senile purpura. Atrophy of the supportive tissue of the cutaneous blood vessels in the old age may cause senile atrophy, especially in the dorsum of the forearm and hand. Then scurvy deficiency of the vitamin C causes defective collagen synthesis, which causes skin bleeding as well as bleeding into the muscles and occasionally into the GIT and genitourinary tract. Then disorders of the platelets produce bleeding disorders by one of the following three mechanisms. Then first is due to the reduction in the number of the platelets, various forms of thrombocytopenias. Then due to the rise in the platelet count, that is thrombocytosis. Then due to the defective platelet functions. So first of all, thrombocytopenia. So thrombocytopenia is defined as a reduction in the peripheral blood count below the lower limit of the normal count, that is below 1,50,000 per ml. Then thrombocytopenia is associated with the abnormal bleeding that includes spontaneous skin purpura and mucosal hemorrhages as well as prolonged bleeding after trauma. After spontaneous hemorrhagic tendency becomes clinically evident only after severe depletion of the platelet count to level below 20,000 is so here we need to transfuse the platelets or transfuse the whole blood. Then thrombocytopenia may result from four main groups of causes: impaired platelet production, accelerated platelet destruction, splenic sequestration and dilutional loss. Right. So drug induced thrombocytopenia करते हैं सबसे पहले तो So drug induced thrombocytopenia. Many commonly used drugs cause thrombocytopenia by depressing megakaryocyte production. In most cases, an immune mechanism of drug formation of the drug antibody complexes is implicated, in which the platelet is damaged as an innocent bystander. And drug-induced thrombocytopenia is associated with many commonly used drugs and include chemotherapeutic agents and certain antibiotics, drugs used in cardiovascular disease, and diclofenac, acyclovir, heparin, and excessive consumption of ethanol as well. Then clinically, the patient presents with acute purpura. The platelet count is markedly lower, often below 10,000 per ml, and the bone marrow shows normal or increased number of megakaryocytes. An immediate treatment is to stop or replace the suspected drug with instruction to the patient to avoid taking the offending drug in future. And occasionally patient may require temporarily support with glucocorticoid, plasmapheresis or platelet transfusions. Then heparin induced thrombocytopenia. Thrombocytopenia due to the administration of the heparin is indistinct from that caused by other drugs in the following ways. First is thrombocytopenia. Thrombocytopenia is generally not so severe to fall to level below 20,000 per ml. Unlike the drug-induced thrombocytopenia, heparin-induced thrombocytopenia is not associated with the bleeding, but instead these patients are more prone to develop thrombosis. The underlying mechanism of the heparin-induced thrombocytopenia is formation of the antibody against platelet factor 4 heparin complex, and the specific antibody activates the endothelial cells and initiates the thrombus formation. And it occurs in a small proportion of the cases after the patient has received the heparin for 5 to 10 days. And diagnosis is made by a combination of the laboratory and clinical features with 4 T's, that is thrombocytopenia, thrombosis, time of fall of the platelet count, absence of other causes of the thrombocytopenia. Then idiopathic thrombocytopenic purpura, ITP. It is characterized by the immunological destruction of the platelet, normal or increased megakaryocytes in the bone marrow. So pathogenesis. Acute ITP is a self-limited disorder. Acute ITP is a self-limited disorder seen most frequently in children following the recovery from a viral illness such as hepatitis C, infectious mononucleosis, cytomegalovirus, HIV infection, and upper respiratory infections, illnesses. The onset of acute ITP is sudden and severe. Right. So the onset of acute ITP is sudden, as the name suggests, and severe thrombocytopenia, but recovery occurs within a few weeks to 6 months. And wait a second. Yeah. So the onset of the acute ITP is sudden and severe thrombocytopenia, but recovery occurs within a few weeks to 6 months. And the mechanism of the acute ITP is by formation of the immune complexes containing the viral antigens, and by formation of the antibodies against viral antigens which cross-react with the platelets and lead to their immunological destruction. Chronic ITP. Chronic ITP occurs more commonly in adults, particularly in women of childbearing age. The disorder develops insidiously and persists for several years. Though chronic ITP is idiopathic, similar immunological thrombocytopenia may be seen in association with SLE, AIDS, and autoimmune thyroiditis. And the pathogenesis of the chronic ITP is explained by the formation of the antiplatelet autoantibodies, usually by the platelet associated IgG. Humoral antibodies synthesized mainly in the spleen. These antibodies are directed against target antigen on the platelet glycoprotein GP2B3A and GP1B9 complex. Some of the antibodies directed against platelet surface also interfere in their function, and the mechanism of the platelet destruction is similar to that seen in the autoimmune hemolytic anemias. Sensitized platelets are destroyed mainly in the spleen and rendered susceptible to the phagocytosis by the cells of the RE system. And the clinical features. So majorly the clinical manifestation is the major clinical manifestation of ITP may develop abruptly in the cases of acute ITP, or the onset may be insidious, as occurs in majority of the cases of chronic ITP. The usual manifestations are petechial hemorrhages, easy bruising, and mucosal bleeding such as menorrhagia in women, nasal bleeding, bleeding from gums, melena, hematuria, and intracranial hemorrhage. Right. Splenomegaly, hepatomegaly may occur in the cases with chronic ITP, but lymphadenopathy is quite common in either type of ITP. The diagnosis of the ITP can be suspected on the clinical feature after excluding the known cause of thrombocytopenia, and is supported by the following hematological findings. First of all, platelet count. Platelet count is reduced and it is usually in the range of 10,000 to 50,000. Blood film shows an occasional platelets which are often large in size. Then bone marrow shows the increased number of megakaryocytes which have large non-lobulated single nuclei and may have reduced cytoplasmic granularity and presence of vacuoles. Then with the sensitive techniques, Anti-platelet IgG antibody can be demonstrated on the platelet surface or in the serum of the patients. Then the platelet survival studies reveal markedly reduced platelet lifespan, sometimes less than 1 hour as compared with normal lifespan of 7 to 10 days. Then the principle of the treatment. Spontaneous recovery occurs in 90% of the cases of acute ITP, while only less than 10% cases of chronic ITP recover spontaneously. Treatment is directed at reducing the level and the source of autoantibodies and reducing the rate of the destruction of the sensitized platelets, and this is possible by corticosteroid therapy, immunosuppressive drugs, splenectomy, and beneficial effects of the splenectomy in chronic ITP are due to both removal of the major site of the platelet destruction and the major source of autoantibody synthesis, and the platelet transfusion are helpful as a palliative measure only in the patient with severe hemorrhage. Then thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. So this is a group. So basically these two diseases, they form a group of thrombotic microangiopathies which are essentially characterized by a triad of thrombocytopenia, microangiopathic hemolytic anemia, and formation of the hyaline fibrin microthrombi within the microvasculature throughout the body. So thrombocytopenia, microangiopathic hemolytic anemia, and microthrombi. So these are the three or this is the characteristic triad, and these are often fulminant and lethal disorder occurring in the young adults, and the intravascular microthrombi are combined predominantly of platelets and fibrin, and the widespread presence of these platelet microthrombi is responsible for the thrombocytopenia due to the increased consumption of the platelets, microangiopathic hemolytic anemia, and the protein clinical manifestation involving the different organs and tissue throughout the body. Then pathogenesis. Unlike DIC, a clinico-pathological related condition, that is activation of the clotting system, is not the primary event in the formation of microthrombi. TTP is initiated by the endothelial injury followed by the release of von Willebrand factor and other procoagulant material from the endothelial cells, leading to the formation of microthrombi. And trigger for the endothelial injury comes from immunological damage by the diverse conditions such as pregnancy, metastatic cancer, high dose chemotherapy, HIV infection, and mitomycin C. And clinical features. The clinical manifestation of TTT are due to the microthrombi in the arterioles, capillaries, and venules throughout the body. Besides feature of thrombocytopenia, the microangiopathic hemolytic anemia characteristic findings include fever, transient neuralgic defects, renal failure, and the spleen may be palpable. Then the diagnosis can be made from the following findings: thrombocytopenia, microangiopathic hemolytic anemia, leukocytosis, bone marrow examination, and diagnosis is however established by examination of the biopsy, which demonstrate typical microthrombi in arterioles, capillaries, veins, and unassociated with any inflammatory changes in the vessel wall. Then hereditary disorders. Depending upon the predominant functional abnormality, inherited disorders of the platelet function are classified into three groups. First is defective platelet adhesion, Bernard-Sallier syndrome. It is an autosomal recessive disorder which inherited deficiency of the platelet membrane glycoprotein, which is essential for adhesion of platelets to the vessel wall. Second is von Willebrand disease. There is defective platelet adhesion as well as a deficiency of the factor 8. Then defective platelet aggregation in the Glanzmann's disease. There is a failure of the primary platelet aggregation and so there is a failure of the primary platelet aggregation with ATP or collagen due to the inherited factors. Then disorders of the platelet release reaction. These disorders are characterized by normal initial aggregation of the platelet with ADP or collagen, but the subsequent release of ADP prostaglandin 5-HT is defective due to the complex intrinsic deficiencies. Then acquired defects of the platelet function include the following clinical significant examples. First is aspirin therapy, and prolonged use of aspirin lead to the easy bruising and normal bleeding time, and this is because aspirin inhibits the enzyme cyclooxygenase and thereby suppresses the synthesis of prostaglandin, which are involved in the platelet aggregation as well as the release reaction. And the antiplatelet effect of the aspirin is clinically applied in preventing the major thromboembolic disease in recurrent myocardial infarction, and several other acquired disorders are associated with. Wait a second. Yeah. Yeah. So several other acquired disorders are associated with the various abnormalities in the platelet function at different levels. These include uremia, liver disease, multiple myeloma, Waldenstrom, microglobulinemia, and myeloproliferative disorders. Then coagulation disorders. So in this we will be studying hemophilia, von Willebrand disease, vitamin K deficiency, and DIC. First of all, so hemophilia is of three types: A, B, and C. C is rare, and we generally don't study C. We study only A and B. So classical hemophilia or hemophilia A is the most common hereditary coagulation disorder occurring due to the deficiency or the reduced activity of factor 8, that is anti-hemophilic factor, and the disorder is inherited as a X-linked recessive trait and therefore manifests clinically in males, while females are carriers because recessive trait right. However, rarely may be true female hemophilics, that is if both recessive are there in one female, XR and XR. So at that time there can be homozygous state in female as well. So that will be a hemophilic female, and arising from the consanguinity within the family, that is daughter born to the hemophilic father and carrier mother. The chances of the proven carrier mother passing to the abnormality to her children is 50:50 for each son and 50:50 for each daughter. And a hemophilic father cannot transmit the disorder to his sons because fathers से सिर्फ Y chromosome is only comes, right, and while all his daughters will be asymptomatic carriers. However, cases without family history of hemophilia are due to spontaneous somatic mutations of the gene coding of factor 8. So still, if even a family history नहीं है तो somatic mutation से भी possible है. Then the disease has been known since ancient time, but Scotland in 1839 gave the bleeder's disease its present name is hemophilia, and in 1952 it was found that hemophilia was not always due to the deficiency of factor 8. It was previously considered believed that there was deficiency of the 9, that is Christmas factor or plasma thromboplastin component, and currently hemophilia A, that is classical hemophilia, is inherited deficiency of factor 8 due to the mutation of F8 gene. B is Christmas disease due to the deficiency of factor F9, and C is due to the factor F10. C is rare and thus we don't study that. The frequency of the hemophilia varies in different races, the highest incidence being the population of the Britain, Northern Europe and Australia. Hemophilia A comprises about 80% of the cases. Western literature reports give an overall incidence of the hemophilia A in 1 in 10,000 male births. Another interesting facet of the hemophilia which has attracted the investigators and researchers is the prevalence of this disorder in the blood of royal families in the Great Britain and some European countries. Pathogenesis. Hemophilia A is caused by the quantitative reduction of the factor 8 in the 90% in the 90% of the cases, while 10% of the cases are normal or increased level of factor 8 with reduced activity. Factor 8 is synthesized in the hepatic parenchymal cells and regulates the activation of factor 10 in the intrinsic coagulation pathway. Then factor 8 circulates the blood complex to the another large protein. Then wolverine factor, which comprises 99% of the factor, um, is basically the combination of the 8 and von Willebrand factor complex, and the genetic coding synthesis and the function of the von Willebrand factor are considered from those of the factor 8 and are considered separately below under the von Willebrand disease. And normal hemostasis acquires 25% of factor 8 activity. The occasional patient with 25% factor 8 may develop bleeding, and most symptomatic hemophilic patients are those who have factor 8 levels below 5%, right? Then clinical features. Patient with hemophilia suffer from the bleeding from hours or days after the injury. The clinical severity of the disease correlates well with the plasma level of the factor 8 activity. Hemophilic bleeding can involve any organ but occurs most commonly as recurrent painful hematoses and muscle hematomas, and sometimes as hematuria. Spontaneous intracranial hemorrhage and oropharyngeal bleeding are rare, but when they occur, they are the most feared complications, right? And laboratory findings. The following tests are abnormal. So white blood coagulation time is prolonged with severe cases only. Then prothrombin time is usually normal. Activated partial thromboplastin APTT and PTTK is typically prolonged, and specific assay for factor 8 shows the lowered activity, and the diagnosis of the female carrier is made by the finding of about half of the activity of factor 8, while the manifest disease is associated with factor 8 activity below 25%. Then principles of the treatment. Symptomatic patients with the bleeding episodes are treated with the factor 8 replacement therapy consisting the factor 8 concentrates or plasma cryoprecipitates. And wait a second. Yeah. So symptomatic patients with bleeding episodes are treated with the factor 8 replacement therapy consisting of factor 8 concentrates or plasma cryoprecipitates. With the availability of this treatment, the life expectancy of even severe hemophilic patients are approaching normal, but the occurrences of AIDS is multi-transfused hemophilic patient has adversely affected the life expectancy. Then the Christmas disease or hemophilia B. So inherited deficiency of factor 9 Christmas factor or plasma thromboplastin component produces Christmas disease or hemophilia B. Hemophilia B is rarer than hemophilia A, constituting about 20% cases. Its estimated incidence is 1 in 1 lakh male birth, and the inheritance pattern and the clinical feature of factor 9 deficiency are indistinguishable from those of classic hemophilia, but accurate laboratory diagnosis is critical since hemophilia B requires the treatment with different plasma fraction, and the usual screening tests for coagulation are similar to those in the classic hemophilia, but bioassay of factor 9 reveals the lower activity. Then the principle of treatment. Therapy is symptomatic hemophilia B consisting of infusion of the either fresh frozen plasma or plasma enriched with factor 9, and besides the expected possibilities of the complication of hepatitis, chronic liver disease, AIDS, the replacement therapy of factor 9 deficiency may activate the coagulation system and cause thrombosis and embolism. Then von Willebrand disease. Von Willebrand disease is the most common hereditary coagulation disorder um, occurring due to the qualitative or the quantitative effect of the von Willebrand factor, and its incidence is estimated to be 1 in 1000 individual of either sex. The von Willebrand factor comprises the larger fraction of factor 8 and von Willebrand factor complex which circulates in the blood. Though the two component of the factor 8, that is von Willebrand factor complex, circulates together as a unit and performs the important function of clotting and facilitates the platelet adhesion to the subendothelial collagen, and von Willebrand factor differs from the factor 8 in following respects. The gene for von Willebrand factor is located at chromosome 12, while that of factor 8 it is X chromosome. Thus, von Willebrand disease is inherited as an autosomal dominant trait which may occur in either sex, while factor 8, that is hemophilia A, is a sex-linked recessive disorder. Von Willebrand factor is synthesized in the endothelial cells, megakaryocytes and platelets, but not in the liver cells, while the principal site for the synthesis of the factor 8 is the liver, right? And while the principal site of synthesis of factor 8 is the liver, and the main function of von Willebrand factor is to facilitate the adhesion of the platelet to subendothelial collagen, while factor 8 is involved in the activation of factor 10 in the intrinsic coagulation pathway. And then the clinical features. Clinically, the patient of von Willebrand factor are characterized by the spontaneous bleeding from mucosal membranes and the excessive bleedings from wounds. There are three major types of von Willebrand disease: type 1, type 2 and type 3. Type 1 disease is the most common, and it is characterized by a mild to moderate decrease in the plasma von Willebrand factor, that is 50% would be active, and the synthesis of the von Willebrand factor is normal, but the release of its multimers is inhibited. Type 2 disease is much less common and is characterized by normal or near normal levels of von Willebrand factor, which is functionally defective. Type 3 disease is extremely rare and it is the most severe form of the disease. These patients have non-detectable von Willebrand factor activity and may have sufficiently low factor 8 levels. Then bleeding episodes in the von Willebrand disease are treated with cryoprecipitate and factor 8 concentrates. And laboratory finding की अगर मैं बात करूँ, these are as under: prolonged bleeding time, normal platelet count, reduced plasma von Willebrand factor concentration, defective platelet aggregation with ristocetin, an antibiotic, and reduced factor 8 activity, because these act as complex. And yeah, I think let's end this session here, and we will be meeting today again at 12 p.m. I think. And thank you so much, guys. Thank you so much, and do refer to the plus course as well. And even if you want to see my special class on the Unacademy app, then also you have to use a code. Otherwise it's free, but you need a code to access that, and code is Virmani, you all know. And ये कोड से आप फ्री स्पेशल क्लासेस अटेंड कर सकते हो. And yeah, that was all for this morning session, and thank you so much for coming, thank you so much for being here. Bye guys, take care, stay healthy, stay positive, and keep fighting for your goals.